Hi everyone.
Good evening, sir.
Good evening, Rudra. क्या हाल है निशान?
Hello, I hope everyone can hear me.
Yeah,
So,
all good, all good. So Prateek is
sorry,
around.
I'll be coming in.
Yes, sir. I am around. Good evening.
Yeah, hi Prateek.
Hi, sir.
So we'll be starting in a few minutes only, Prateek, है ना? I
Yes,
guess,
sir. We'll start at 5:30 itself.
8 minutes. Yeah.
Yeah. We have also started the streaming on YouTube. And
Okay, great. And Dr. Jagandeep and Dr. Chetan has joined. No.
I don't see them.
Okay, and Dr. Manish Agarwal will be joining or not? Any idea?
Sir, आपने बात किया है उनसे?
No, I
have
didn't
not.
speak to him. Okay, I didn't speak to him. Well, I thought it's you. Okay, no worries. We'll coordinate.
Okay.
Okay. So I think everyone is knows each other. So I'll introduce Dr. Dishan Khan first. Rudra, Dr. Dishan is trained from Birmingham
Okay, sir.
in oncology.
Okay.
So he practices at Pakistan, Peshawar. Dishan.
Yeah, I saw it, sir.
Yeah.
Yes, I
And-
got back in 2017.
Yeah. So and Rudra was Dishan our fellow. He finished last year. He finished 3 years at TMH. Now he is practicing in Raipur and all others, all like almost full central India he manages. He roams all around. Yeah, great.
job.
And then Dr. Jagandeep is there. I think he still has to join. He is also trained from Delhi. Now he practices at Chandigarh.
Yeah.
Yeah. And Dr. Chetan Anchan will be joining. He is from Mumbai. And he is at multiple hospitals, mainly Jupiter Hospital in Mumbai. He is also like quite a senior guy, senior to me, senior to Dr. Gulia. So he was like one of the earliest fellow of TMH and now in practice for so long. And we have Dr. Prateek. Prateek is also like ex-TMH alumni, ex-TMH, and he's also practicing in Mumbai. And Dr. Jaimin Shah, he's also a ex-TMH fellow, now practicing at Ahmedabad, Gujarat. And everyone knows me. Yeah. So I am Manish. I am also a TMH alumni, and I am currently at Tata Memorial Hospital only, working as associate professor. Yeah. So we'll be starting with 2 lectures to understand the limb salvage, followed by we'll do a case-based discussion. Okay, where I'll require active inputs from all my panelists. Pratik, Dr. Gulia will be joining to start with, or we need to start?
So we will start. Gulia sir ने ऐसा कुछ बोला नहीं है.
Okay.
We can
No
start.
worries.
If Manish Agarwal sir is not joining, so then maybe you can give the introduction to the session, and we then go on.
No problem. No worries. So we still have 5 minutes to go. Yeah.
The first talk is by Jagandeep. So maybe just give him. Should I give him a call?
I think I saw him maybe. Just give him a call otherwise. He didn't join, not till now.
No, he
No,
has
sir.
not joined.
So then give him a call. I'll just message him also. So how is it going, Vishan? Fever, viral? I think you are mute, I guess.
Yes,
Yeah,
I
no.
try to keep myself on mute.
Okay.
I'm actually absolutely fine. Otherwise, I've got no fever, but it's just the viral laryngitis, which makes me feel very funny in front of my patients. So it's been going on for the last 2-3 days, and my mother's been pumping in a lot of Joshanda in me. So I don't know if it's going to work or not.
Same thing, like I am also down with now. I am having a basically cough more or less. Like some laryngitis with cough. 2 days I was down with fever. Now fever is settled, but then lot of irritation in the throat. And in between bouts of cough. Not laryngitis, maybe a little more lowered on bronchitis, something like that. But it gets like a bouts of cough.
Actually, the weather is changing here as well. So you have to turn on the fan on a very slow pace. Otherwise, it gets a bit warm. But when you turn it on, you feel cold. So it's that time of the weather at the moment. So perhaps a bit of it is due to that as well.
In Mumbai so is already hot, I guess. Central India is also must be hot. Northern India, maybe it will be the similar weather, like change of weather. So Dr. Jamin has joined. Hi, Jamin.
Hi. Hi, everybody.
All good?
Well,
You are fine? No fever
No.
with you?
Mm,
Very good.
yes, just settled down, but severe laryngitis.
Acha, you also have a laryngitis? Okay. All
Yes,
of us.
yes.
All of us are
Well,
down with the same.
Maybe it
Yes,
was something in Chennai.
Maybe. The
Maybe.
AC was so cool that I think the virus has quite came from there.
Maybe you had too much of a cold beer or something.
I wish I could have that.
Okay. Chalo. I think we'll begin in 2 minutes. Hi, Jagan.
Hi, sir.
All fine at your end?
Ha bolo.
Great.
Ha bolo.
Jamin, mute, please. Yeah. Okay. So, Pratik, we are good to go.
We'll wait for 2 minutes. Chetan sir
Yeah.
has not joined yet.
Okay. And we'll be going live in 2 minutes, or we are already live?
On YouTube, we are live. The recording will start in 2 minutes.
Okay, recording will start in 2 minutes. Great.
So I have dropped Chetan sir a message. So maybe during Jagan's talk, we can give him a call as well if he's not
That's
joined
fine.
by then.
Hopefully, I think he will join in some time. You have dropped him a message now already?
Yes,
Okay.
sir. I've sent the Zoom meeting details.
Great. Pratik, we'll begin.
Yes, sir. I think we can start. It's 5:29.
And my clock is 5:30. That's fine.
Yeah.
Okay, we'll start.
Yes, sir.
So, yeah. So, welcome back, everyone. Like all delegates, dear friends, my colleagues. So, this is now the 8th session by Sarcoma Education Foundation on teaching classes on orthopedic oncology. And today we'll be discussing limb salvage. So, basically, what we'll be discussing today is to understand what are the basic principles and as well as like what are the challenges which a surgeon face during a limb salvage surgery. So this will be the first talk by Dr. Jagandeep Singh, followed by we'll be discussing the reconstruction options in limb salvage. It's a very vast topic. I have requested Dr. Chetan Anchan to summarize this in 15 to 20 minutes. And we'll be discussing site-wise and the surgical-wise, like whether we are doing an intercalary or an intra-articular section. So what are the various reconstruction options after a limb salvage surgery? Followed by, we'll have a small panel discussion for around 45 minutes where I'll be putting few cases, and we have an esteemed panel comprising of Dr. Zishan Khan from Pakistan, Dr. Rudra Pratap from Raipur, Dr. Jaimin Shah from Ahmedabad, and Dr. Chetan Anchan and Dr. Jagandeep. So we'll be putting cases one by one to take their inputs to understand what are the reconstruction options in those cases. And in the last, we'll have a small quiz for 10 to 15 minutes where we'll be putting almost 10 questions to you where you can answer and win prizes. So not to waste any further time, let me invite Dr. Jagandeep Singh Virk. Dr. Jagandeep is a consultant in Chandigarh. He works at Paras Hospital. He's trained from Chandigarh and Delhi, and he'll be speaking on limb salvage surgery principles and challenges. So over to you, Jagan.
Manish, sir. The principles and challenges in limb salvage surgery. Can you see my screen, sir?
Yeah, Jagan, you are visible. Yeah, you are audible also.
Thank you. So I'll be covering the principles and challenges of limb salvage surgery. So a small historical account, first of all, that surgical treatment of primary bone cancers historically, especially in the limbs, was amputation and a disarticulation. But as early as 1879, it was realized that most of these ablative surgeries, be it an amputation or disarticulation, will not result in a cure in vast majority of the sarcomas. There was only a 10 to 20% cure rate with surgery alone. So this was a landmark paper in NEJM by Link et al. In 1986, where they established the role of chemotherapy in improving the survival outcomes of sarcoma patients. So there was a paradigm shift in the management of sarcoma patients from an amputation or disarticulation to a limb salvage surgery. So this was paralleled, the effective chemotherapy which came into being. It was paralleled by an improvement in our imaging and staging techniques like MRI, CT scan, improved surgical techniques, better understanding of the margins, improved reconstruction methods, availability of modular endoprosthesis, and now even customized tumor prostheses are readily available. And now limb salvage surgery has become the norm at most of the centers, and more than 90% of the patients of bone or soft tissue sarcoma undergo a limb salvage surgery at most of the specialized cancer centers. So we have to understand that when can we do a limb salvage surgery in a sarcoma patient? So there are two basic principles. First principle is that we should be able to achieve an adequate wide margin. So what do we understand by adequate wide margin? I'll be covering subsequently. And the second most important principle is that whatever we have salvaged at the end of a limb salvage surgery, that limb should provide a function which should have adequate motor units, and should provide a function which is superior to that offered by an artificial limb, as would have been in an amputated patient. So limb salvage surgery basically can be divided into two main parts, the resection and the reconstruction. I'll be covering the resection part. Dr. Chetan Anchan will be covering the reconstruction part. So coming on to resection, they are basically three main types of resection, depending upon where our plane of resection is going through. So if we are opening up the joint, we are entering into the joint, then it is called an intra-articular resection. If we are taking out the joint in toto as part of the disease clearance, it is called as an extra-articular resection. And when we are sparing the joint, then it is known as an intercalary resection when the disease is in the diaphyseal or the metaphyseal region. Coming on to the concept of resection, the most important concept is the concept of margins. So this was given by Anneking et al., and he divided margins into four main types. The radical margin or a radical resection is basically for amputation, disarticulation, or when we have to do a compartmental resection. A wide resection is what we perform in limb salvage surgeries, where we take out a cuff of normal tissue around the tumor or the sarcoma. Marginal and intralesional excisions or resection margins are reserved in case of benign bone tumors or benign soft tissue tumors. So for sarcomas, we have to achieve wide margin. So by wide margin, we mean that we have to take out a cuff of normal tissue, which should be covering all around the tumor. And usually it means removal of about 2 centimeters of normal tissue, or it should be a good anatomical barrier like a fascia or articular cartilage. And as far as the bone is concerned, how far we have to cut or we have to take the osteotomy away from the disease, it has to be at least 3 to 5 centimeters away from the level of involvement. With time, it was realized it's not the absolute metric width of the surgical margin which is as important as is the quality of the tissue which we are taking as margin. So this gave rise to the barrier concept, which was given by Kawaguchi et al. In 1995. And they defined these tissues which were taken as margin as barriers. So barrier was considered to be any tissue that has resistance against tumor invasion. It can be a muscle fascia, joint capsule, tendon or a tendon sheath, epineurium over the nerve, vascular sheath over the vessel, cartilage, pleura, or peritoneum. So they divided these barriers into thick and thin barriers. So a thick barrier is equivalent to a physical distance of about 3 centimeters of tissue. And it can be any physically strong membranous tissue like an iliotibial band, presacral fascia, joint capsule, periosteum in an infant or young child, which is thicker as compared to that in adults, where it is considered to be a thin barrier. So a thin barrier is a weaker membranous tissue like a muscle fascia, periosteum in an adult, vessel sheath, or epineurium. Growth plate again was considered to be a thick and thin barrier. So like in a smaller child where the physis is wide, it is considered to be a thick barrier equivalent to a 3 centimeter distance. And a linear appearance of a growth plate like in an older child is considered to be a thin barrier. Joint cartilage was considered to be a 5 centimeter of normal tissue thickness or cuff. So why giving adequate margins is important, as we can see in this Kaplan-Meier survival curve, that when we give adequate margins, the local recurrence-free survival rate increases, and this leads to an increased cumulative survival as compared to inadequate margins. So this we have already covered in our previous lectures, that what are the principles as far as planning for a limb salvage surgery is concerned. We have to get appropriate initial investigations whenever we are planning a limb salvage surgery, which involves an X-ray of the local part. It should cover both the adjacent joints. MRI of the local part is usually required as part of the local restaging. We can see the intramedullary extent, the soft tissue extent. We have to see for any skip lesions, proximity to the main neurovascular bundle, see for any joint involvement, planning for our biopsy, and ultimately planning for a surgery also. An appropriate MRI should have a scale that we can calculate the disease extent. We can plan our osteotomies accordingly. It should have a T1 star coronal and plane sequences for seeing the marrow extent of the disease, for planning our bone margins. It should have a T2 axial sequences at the level of disease for planning our soft tissue margins. This has again been covered in the previous lecture, that how to do appropriate needle biopsy. But what I would like to reinforce here is that ideally it should be done by the same surgeon who will be ultimately performing the limb salvage surgery, or a member of his same team, so that they know where exactly will be planning the line of resection when they have to perform the future limb salvage surgery. And usually in the limbs, it has to be a vertical incision and not a transfer or a horizontal incision. So a case in point like this is a biopsy-proven case of Ewing sarcoma in the diaphyseal region of the humerus. These are the pre-chemotherapy MRI images, where we can see there is a lot of soft tissue edema. There is peritumoral edema, soft tissue extension. And once the patient receives chemotherapy, we do a local restaging again with a full-length MRI contrast enhanced, where we again plan our bony and soft tissue margins. We get an X-ray done because we want to see what is the osseous response to the chemotherapy, and that will influence how we do the reconstruction part. So this is what I mean, that we have to plan our osteotomies, because then if we have a scale or we have a software, we can calculate where exactly we have to plan our osteotomies if we have to do an intercalary resection. The biopsy scar mark has to be excised in toto, as we can see in this figure. We have to island it out, and we have to excise it right up to the resection specimen, as we can see in the second figure. Preserve all the vital structures. Like in this particular case, all the major nerves and vessels have to be preserved, and the resected specimen has to be taken out with wide margins, and appropriate reconstruction has to be performed. So another case of a proximal tibia osteosarcoma, not an appropriate X-ray, that is not covering the whole part of the bone. But we can see that in this MRI, this is what I mean by a full-length MRI. We have to see for the marrow extent of the disease. There shouldn't be any skip lesions. We have to see the axial images for planning our soft tissue margins. And again, in this case, as an incisional biopsy was performed, we have to island out the whole incisional biopsy scar mark, take good healthy margins around the specimen, and accordingly a reconstruction has to be performed. So in this case, again a biopsy proven case of osteosarcoma of the proximal tibia. we can see that the disease is abutting the physis or the growth plate. And in this case, if we want to do a joint sparing or an intercalary dissection, accordingly, we can plan our surgery. Again, we can see that wide margins have to be taken along the biopsy scar mark. We have to plan our osteotomies, and an ECRT was done in this particular case. This is again a straightforward case of osteosarcoma of the lower end of the femur, where we can see that the disease is present in the medial femoral condyle predominantly, and the biopsy has been done again on the medial side. Biopsy scar has to be excised in toto. The main neurovascular structures have to be preserved, and a reconstruction with an endoprosthesis was performed in this particular case. Another case of a biopsy-proven high-grade sarcoma of the lower end of the femur. So these are the post-chemotherapy X-rays. This is an MRI with which the patient presented to us from outside. This is not a contrast-enhanced MRI, not a full-length MRI. So this is not an appropriate MRI where we can plan where exactly we need to, if we are planning a joint sparing surgery, what is the extent of surgery and how do we plan our osteotomies. So this is a full-length MRI. In the stir coronal T1 images, we can plan our osteotomies and accordingly. And then in this case, also an incisional biopsy was done. So it has to be, the biopsy scar mark has to be islanded out, which includes the hatch marks around the biopsy scar mark. Do our osteotomies according to the preoperative plan, preserve the neurovascular bundle, and under fluoroscopic guidance, as per preoperative templating, the osteotomies were done. The section was performed, the specimen was taken out with wide margins. In this particular technique, cryotherapy technique was involved to reconstruct the tumor. Another case of proximal femur osteosarcoma. In this, we can see that that there is intraosseous disease, but there is some part of the disease, as we can see on the axial sections, which is going and abutting on the sciatic nerve. So around the vital structures, I would like to mention here that our margins, we can have planned close margins around vital structures such as nerves and vessels. But it has to be a R0 resection. There can't be any microscopic contamination whenever we are contemplating a limb salvage surgery. The benefit of getting a full-length MRI, as in this case, we can see this is a lower-end femur osteosarcoma with a skip metastasis in the proximal part of femur. So we had to plan for a total femur resection and a reconstruction with a total femur endoprosthesis. So that is why getting a full-length MRI is very important. Coming on to challenges in limb salvage surgery. So this is a very common challenge we all come across. It's poorly based biopsy scar marks, especially transverse incisions, like in this case, placed over the popliteal crease, which is contaminating the whole popliteal neurovascular bundle. And hence limb salvage surgery is out of question in this particular case because the main neurovascular bundle has been contaminated by the biopsy itself. Another scenario we commonly face is long incisional biopsies, which have been done with long hatch marks. A drain has been taken out from another side, not in line of the biopsy incision. So in this case, again, doing a limb salvage surgery becomes very, very challenging. We have to use a lot of free flaps, maybe local transpositional flaps, take help of a plastic surgery team. There is chances of flap necrosis, and ultimately the patient landing up in an amputation. Another case in which we can see this was the case of margin positive soft tissue sarcoma excision. This was a myxoid liposarcoma. Again, patient had a improperly based incision of the previous surgery. Margin positive excision was done, so we had to revise the excision, take out with wide margins, including the hatch marks of the previous incision. A large defect was left behind. We took help of a plastic surgery team where a local transpositional flap was done, and we could go to a good soft tissue reconstruction. Another challenge we face in limb salvage surgery are large volume disease. So like in this case of a biopsy proven proximal humerus osteosarcoma with a satellite nodule, we can see that the main neurovascular bundle is abutting or lying right over the disease, as we can see in this axial section. So, but in this case, again, we can have planned close margins, as I already mentioned, along the vital structures, dissect off the main neurovascular bundle, and accordingly do a limb salvage surgery. Another case of soft tissue sarcoma in which in the pre-surgery MRI, we were not able to visualize the radial nerve. Most likely it was compressed inside the disease, especially around a vital structure like the radial nerve. As we can see in these intraoperative images, we can see that the nerve appears to be entering into the tumor. In the second image, we can see it is entering here and exiting from this side. But doing sharp epineural dissection over the nerve, we were able to spare out the nerve and take out the tumor with negative margins. Another very large tumor in the adductor compartment, soft tissue sarcoma going into the posterior compartment. Here again, we have to map out the disease, see where our neurovascular structure is lying, do an MR angiogram in such cases. And again, with careful vascular dissection, we were able to dissect out the superficial femoral artery. We had to ligate the profunda femoris, take out the sciatic nerve, take out the resection specimen with wide margins, and spare all the vital structures and give the patient a reasonably good function. So this is what I mean, like these are two case scenarios of a soft tissue sarcoma in the lower end of the thigh. In the first example, we can see that the sciatic nerve is completely encased in the soft tissue mass. So taking out this vital structure in this particular scenario is very difficult without opening up the tumor. So in such a scenario, doing nerve sparing limb salvage surgery is very difficult as compared to this scenario where we can see that the nerve is abutting over the soft tissue mass, where we can do a sharp epineural dissection over the nerve and take out the nerve. So this is the first scenario where we can see that the nerve is completely entering into the tumor mass. So in such cases, either we have to resect the nerve and do a nerve grafting. And this is the second scenario where we can see that the nerve is lying just over the tumor. We can do a planned closed margin, do sharp epineural dissection. The epineurium itself will act as a margin and spare out the nerve. Another challenge we come across sometimes is vessel encasement, like in this case of biopsy-proven Ewing sarcoma. We can see that the peroneal and the posterior tibial vessels were encased in the middle third of segment of the disease. So in this case, again, we got an MR angiogram. The flow in the anterior tibial artery was not that good. So in this case, since we were able to preserve the posterior tibial nerve, we planned a vessel reconstruction of the posterior tibial artery with a contralateral saphenous vein graft from the contralateral leg. So vessel encasement or the major vessel encasement again is not a contraindication to limb salvage surgery. We can do a vessel resection and a vessel reconstruction, provided we can get wide margins around the tumor. And again, we can, if we are able to spare the main nerve. Many surgeons, they have this misconception that pathological fracture is a contraindication to limb salvage surgery. So pathological fracture is not a contraindication to limb salvage surgery, as we can see that in this case, a proximal humerus, biopsy-proven proximal humerus osteosarcoma with a pathological fracture. We just have to splint the patient, give the patient some immobilization, start the patient on chemotherapy. Usually in Ewing's and in osteosarcoma, patients do respond to chemotherapy. As we can see in this post-neoadjuvant chemotherapy X-ray, the disease has nicely ossified. We have got post-neoadjuvant chemotherapy MRI done, planar margin. There is some disease we can see on the axial sections, which is intra-articular going into the glenoid. So we planned an extra-articular resection in this particular case, and reconstruction with a K-nail, cement, and mesh plasty was done, and giving the patient reasonably good elbow and hand function. Another common challenge we come across, apart from a pathological fracture, is joint contamination. Like in this case of a biopsy-proven lower-end femur osteosarcoma with a patch fracture, we can see on the MRI that the disease is entering into the suprapatellar pouch. So in this case, again, it is not a direct indication that we cannot do a limb salvage surgery and we have to do amputation. In this case, again, we gave the patient neoadjuvant chemotherapy. We can see that the tumor has nicely ossified. And since we have to plan our margins according to the pre-neoadjuvant chemotherapy or the extent of disease, which was maximum, so we had to do an extra-articular resection. Like in this case, we did an extra-articular resection and we did not enter into the knee joint and took out the knee joint in toto and reconstruction with a double-barreled fibula. and a knee arthrodesis was performed. Another common challenge we come across is implant in situ. Like this was a case of low-grade primary sarcoma of the bone with a pathological fracture neck femur, and a bipolar prosthesis was done from outside. And the disease kept on increasing, obviously, because the disease was still left in the metadiaphyseal region of the femur. Apart from that, the patient had a large soft tissue mass. So because of the metal in situ, there was a lot of artifact on the MRI. There are special sequences on the MRI, like the Mars protocol, we can get done to better study the MRI and plan our resection accordingly. We also got a PET CT done as part of the systemic staging. So, and subsequently we had to perform limb salvage surgery, as we can see that we were able to take out the entire mass with negative margins, spare the main superficial vessels, superficial femoral vessels, and the sciatic nerve, and reconstruction with the proximal femur endoprosthesis was performed. Another challenge is that sometimes patients present to us with fungating masses. Fungation per se is not a contraindication for performing a limb salvage surgery, like in this case of an extraskeletal loss of tissue Ewing sarcoma. When we got the MRI done, we saw that we would have been able to spare the main neurovascular bundle. We excised the fungating part in toto and took the bone as margin, since it was abutting over the bone. Did the reconstruction again with a K-nail cement spacer, and we can see that the wound has gone to heal up nicely. So despite all these challenges, there are scenarios where patients present with previously performed intralesional surgeries which have contaminated all the tissue planes. There is pan-compartmental disease with encasement of the main neurovascular bundle, or the patient present with fungation and sepsis. So these are all indications where we cannot perform a limb salvage surgery, and amputation or a disarticulation rotation plasty is the only option. So the take-home message from this presentation I would like to give, that limb salvage surgery is the norm these days for primary bone and soft tissue sarcomas, and is achievable in more than 90% cases. Adequate imaging, proper biopsy and planning is vital. We have to get adequate wide margins, follow the margin concept, and we have to preserve sufficient motors in order to give the patient a reasonably good function. And planned close margins along vital structures is acceptable as long as we are doing an R0 resection. Thank you.
Yeah. Thank you very much, Jagan. It was an excellent presentation, and I think you have covered almost all aspects of limb salvage surgery, what a surgeon faces. So we can take some questions, Pratik, now. There's time.
Yes, sir, we can take, or you can discuss in the panel also, whichever.
I think if someone has questions, we'll take it now. We can reduce the time of panel, because this is very important for the residents to understand the concepts.
Yeah.
If there are any questions.
We expect to have some questions.
Yeah.
There should be questions. Then only there is participation.
So,
Otherwise,
Jagan,
it is just a monologue.
So if no one is
Yes.
asking, I'll ask you a question. Like, suppose you have we'll go with the standard situation. We have a distal femur osteosarcoma.
Right.
Okay. So how do you identify your margins? Like, what is your goal? Like longitudinal margins, circumferential margins. So what all you take into consideration, and what is the minimum margin that you want to? You are saying planned close margins are acceptable, but
Right.
are you taking in the planned close in the lengthwise also, or only in circumferential, or what? In which situation you are accepting a planned close margins?
So planned close margins, sir, we are only accepting when there is a large soft tissue mass which is abutting the vital structures, like in a case of a lower end femur osteosarcoma, it is abutting the main vessel or the main nerve. When we have a purely intraosseous disease, like there's a lower end femur osteosarcoma, purely intraosseous disease, no soft tissue extension or mass. In that scenario, sir, we can take wide margins along the main neurovascular structure. We don't need to be very close to them. There is a fat plane. We can actually take the entire fat plane along with the resection specimen. when the disease is totally intraosseous, we can be even wide as
So
far as
that will be a rare situation.
right.
Like a pure intraosseous osteosarcoma, I don't think we'll see any time.
Yes.
Okay, so more or less you see an osteosarcoma with an extraosseous component.
Yes.
So in that case, how do you decide on your margins?
So first is that preoperative imaging, like the MRI, is vital for planning our margins.
No, that is fine. Like we did an imaging. I just want to know what margins you are going to plan. Like for the
So-
resident, they need to understand now they have a picture of an
Yes.
osteosarcoma with an MRI there. So they
Yes.
need to understand how they are going to plan the resection.
Right. So as far as the bony margins are concerned, sir, if I'm planning an osteoarticular resection, right,
Yeah.
and I have to reconstruct it with a tumor prosthesis. So my proximal osteotomy can be well above the disease. I can take a 3 centimeter margin. I can plan it on the STIR T1 coronal sequence that the disease is, till 10 centimeters proximal to the medial joint line. I can take my proximal osteotomy at 13 centimeters.
So basically,
As
you
far
will
as-
plan on T1 coronal, your longitudinal bony margin.
Longitudinal bony margins. So
Okay.
as far as the distal margin is concerned, since I'll be performing an osteoarticular resection, the cartilage itself will be acting as a good margin.
Okay,
As
so
far as resection is
that
concerned.
takes care of your longitudinal
Bony
margin.
margins.
What about the circumferential margin?
So as far as the circumferential margins are concerned, sir, in a lower end femur osteosarcoma, I will be taking at least the vastus intermedius as the anterior margin. That will be my
Great. Yeah.
anterior margin. And at no point, even like when I'm doing my proximal dissection, I will not be, violating the periosteum if I'm taking the bone cut.
So that is a
whatever
very
periosteal-
important concept which you have just said. Okay, that is very important for the residents because like in distal femur also the muscles are layered. Okay, so more or less you have to leave the vastus intermedius on the tumor with its fascia. So that gives you a good circumferential margin anteriorly. And posteriorly, because as Dr. Jagan has already told you, like most important structure, nerve and the vessel are covered by epineurium or the perivascular tissue. So we need to dissect in that plane. So all that helps in having a circumferential margin. Okay, that is what you want to say. And
Yes.
we know on a qualitative basis that even the thin fascia actually equates to a 2 centimeter margin.
Right.
So there are some questions, Jagan. I think we'll take them very fast. So first is like pathology report does not reflect the margin is a common scenario, especially barrier concept is not reflecting in the HPR report. How to deal with it in the learning curve?
So I have practically faced this situation that you have to, personally speak to the pathologist that whenever they are giving like the anterior margin, they just write it as 2 mm or 3 mm in the report. They have to actually write that what was the nature of the margin, like it was a vastus intermedius muscle. So they have to mention it in the bracket that it was a muscle. If a lateral margin, supposing is the tensor fascia lata, even if the thickness or quantitatively that tissue is only 1 or 2 millimeter wide, they have to mention it that it was fascia and that we know that TFL is a thick fascia equivalent to a 3 centimeter. So this has to be coordinated with the pathology team that in their reports, they have to mention apart from the just the physical distance of the margin, they have to mention maybe in brackets also that what exactly is the nature of the margin which they are seeing on the specimen.
My question is to Dr. Chetan and Dr. Zishan. Both can answer this. I also face a lot of difficulty in this getting an exact qualitative margin in our pathology report. And more or less, we accept a clear margin report or a whatever, like what if you get a 2 mm margin. So how do you go in your practice? Like Zishan first and maybe then Dr. Chetan can answer. Like if there is any R concept you use or you just accept whatever the report that you are getting.
So, Manish, what I do and what I've learned whilst training is that the maximum amount of information that you provide to your pathologist will yield a more quantitative result for you. And on occasions, I have to draw pictures on the request form. Sometimes I give them a call and we discuss it with them. So that is the only way where you can get the exact answers that you want for your surgical specimen. So that is the first part. The second part is, yes, there is always some confusion. As surgeons, we always are quite delighted when we see an R0 margin. And it's an arbitrary term. We do not know what an R0 actually means. I mean, at times when you are operating in an anatomically constrained area, just say, for instance, you are doing some tumor around the foot or the hand, it's very difficult to get that circumferential margin of at least a centimeter. And that is where even a couple of millimeters margin is an R0 margin, and it works very well. On the contrary, in certain instances where you've achieved a couple of centimeters margins and you're quite happy, and then after a couple of years, you see the patient coming back with a recurrence. So it's a very difficult one, I think. And that is where the concept of personalized chemotherapy or personalized therapy for sarcomas is being floated.
So Dr. Chetan, how do you deal with this in your practice?
Yeah, this is, there is no easy answer to this question. Where, where you can actually quantify margin is where you can actually take measurement, because that is quantitative. So in the bone, it is not difficult because you can measure it based on the MRI, you can measure it on the specimen. Qualitative margin is what we describe. And I often feel that it is not so easy for the pathologist to, define it. The fascia is easy for us to identify when we are operating. So I think it is more about how comfortable you are with this specimen that you are resecting. So I think it is primarily the surgeon's responsibility to see that he takes adequate margins during surgery, and that is based on a lot of correct planning, based on the imaging and based on your clinical judgment. And if you have enough experience, you can actually sense it where you are, basically risking with the margins. And if I have any such specific concern, then it is my job to point out to the pathologist that this is where I am concerned. Handing over a huge specimen to the pathologist and expecting them to study it, and cut it into pieces and figure out where was the close margin, I think it is expecting a bit too much from them. If I have concerns, then I have to, draw their attention to any particular areas. And in fact, that is where we can take help of frozen section, because I'm really concerned about margin. I would probably use the service of frozen section to figure out whether I am close or not. But having said that, I think one should not really be in a situation where you need such a help, except in very, very selected cases. Otherwise, you have to plan your margins better than that. I mean, playing with margin is not at all a safe thing for your patient, because our primary responsibility when we are dealing with resection of a sarcoma is to achieve adequate margin at any cost.
Very rightly said, and this is what is our policy also at Tata Memorial Hospital. Yes.
I was at Japan with Dr. Kawaguchi's team. There, the grossing would be done by the surgeon himself, not by the pathologist, because he knows exactly what he was doing. So they would take the specimen, they would gross it, they would grade it, and then give it to the pathologist.
Yeah. So very rightly said, sir. This was our policy also at Tata at TMH. Like what we do is, if we are not very happy with one of the margin, we ink it. So being truthful to your margins is also very important. We ink that area and tell the pathologist this is the area where you specifically looked in. We know we will not be able to change much after the report, but at least being truthful, conveying your information to the pathologist is of an utmost importance, so that you get an appropriate report and accordingly you can act. So I think in orthopedic oncology, it's like the truthfulness to the pathologist is very important, and we need to accept that. So we always ink a close margin if we feel that, okay, we are close here, so that the pathologists are much more aware of. Yeah. So
I have a question to Dr. Jagandeep. Dr. Jagandeep, excellent presentation. I want to ask one question which Dr. Himanshu has also asked in the chat box, that does the response to your near adjuvant chemotherapy governs your call for a limb salvage? If there is a bad response, assuming there is no gap in the chemotherapy, will you take a call for a amputation or a limb salvage? So what are your protocols for that?
So we have to be very clear that we have to decide our margins or the disease extent depending on, the MRI showing the maximum extent of the disease. It's not like in the pre-neoadjuvant chemotherapy MRI, if the disease extent was more, and on the post-neoadjuvant chemotherapy MRI, we can see that there is some area which was showing disease which is not there anymore. We have to take our margins according to the MRI which is showing the maximum extent of disease. Sometimes it happens is that because of peritumoral edema, we are not able to exactly visualize what exactly is the edema, what part is the disease. So in those scenarios, I think doing a local restaging or doing a MRI again before the surgery makes a lot of sense, because we have to locally restage it again in order to plan our margins.
So Rudra, if I can add into that, what you are asking is like if there is a progression during a neoadjuvant therapy, so do you still consider limb salvage? That was the question, I guess.
Yeah, obvious clinical and radiological progression, maybe appearance of new skip or something like that.
Yeah, so basically when you see a program, I think someone has to mute himself. There is someone who is talking in between. Yeah. So the answer is quite straightforward, Rudra, in the sense that you need to restage the patient if there is a progression. But yes, sometimes it is because of the necrosis also that the tumor increases. Actually, the tumor is responding well to therapy. So as long as you are able to achieve a wide margin post neoadjuvant therapy, you can still go ahead with the limb salvage if your restaging is negative. Fine. So if you're not able to get a wide margin in your post neoadjuvant therapy imaging, you might have to consider an ablative surgery. Otherwise, you can go ahead.
Okay.
Yeah. So we'll proceed with the next talk, and then we can take questions in the panel. So I invite Dr. Chetan Anchan. Dr. Chetan is a consultant at Jupiter Hospital and in the specialty surgical oncology. So, sir, over to you for reconstruction after bone tumor resections.
Thank you. Can you hear me?
Yeah, sir. We can hear you. We can see your slides.
Okay. I think Jagannath has made my life really easy because he has already covered most of the principles, which is in fact most important in tumor resection. Of course, covered a lot of the reconstruction part also. So basically, any sort of limb salvage surgery has two major steps. One is tumor resection, and wherever it is indicated, there is a part of the procedure of limb salvage called as reconstruction. So I would say this is the less important part of the whole reconstruction procedure. In fact, nowadays it is quite easy to do reconstruction if you know how to do a good resection. Why reconstruction has become easy? We owe that to this thing called as mega prosthesis. About say 30 years ago, we didn't have these, and most of these patients would probably end up in an amputation. But mega prosthesis has revolutionized limb salvage. In fact, we probably owe our specialty to mega prosthesis as orthopedic oncologists. Otherwise, amputation, I guess, anybody would be doing. So mega prosthesis is the one which has responsible probably 70 to 80% of the limb salvage procedures that happen all over the world. So what is a mega prosthesis? Mega, as it says, is large. Prosthesis means an implant. And what we now use is a modular mega prosthesis system. What is modular? Modular means it comes in various components with various sizes of length, girth, and for various anatomical locations. Like here, what we are seeing is a indigenously designed and manufactured. In fact, this is the Restore system, which is probably the most commonly used system for limb salvage in India. This was designed at Tata Memorial Hospital, and it has gone through several generations. And this is what we sort of use now. This on the left is the one for the distal femur. One on the right is for the proximal tibia. And as you see, it has got different parts, and all these parts can be assembled during surgery. They come in boxes which are sterilized, and they come in different sizes and different configuration, different dimensions, and all of that give you a lot of modularity. That means you can actually create an implant on table. Earlier, we used to have custom-made implants. Custom-made means they would be manufactured specifically for that particular patient. So we had to give measurements to the company and they would manufacture that implant and that would come and we had to use that. And that was a bit challenging because then you have to be very accurate with your resection. You can't have any errors. And if there is any sort of disease progression, then your implant will be inadequate. And those were quite tricky times for us. But with modularity, you can, it gives you a lot of freedom. You can resect more and you can easily reconstruct that kind of defect. So these are the various separate components. Sorry for these old images that I have used. So after assembly, you get these implants. One on the top is a distal femur implant and the lower down is the tibial resection component. So now we'll see the various applications. Now, in fact, mega process is what we can use for most of the common locations of bone tumor. That is primarily disease around the knee, proximal femur, proximal humerus, and around the elbow, that is distal humerus, entire humerus, and entire femur. So as we all know, knee is the most common site for any bone tumor, and this is where the mega process has been revolutionary. This is a patient with lower end femur osteosarcoma, undergoes a wide excision and a reconstruction with a mega process. Now, in mega processes, there are a lot of different variants. I have not really covered all that because that is a very huge topic, and there are a lot of different ways in which you could do reconstruction. This is just to give you an idea about what mega process is and what all it can do. So here is a fixed hinge mega processes. This is the indigenous design implant. There is something called as rotating hinge. I have not covered that. You probably just need to be aware of that. So after a major distal femur resection, this boy is able to have excellent range and he is able to walk very well. Of course, it is not just a skeletal reconstruction. You should also be able to preserve significant amount of muscle tissue for him to have good control over the knee. Not everybody may walk like this. And the other thing is you have to preserve the nerve and you will have to have good soft tissue cover for the implant. So there are a lot of other prerequisites to only working on the bone may not give you a favorable outcome. This is a patient with apparent tibia osteosarcoma, again underwent a resection with and reconstruction with a mega process. Generally, in proximal tibia, the functional outcome is not as good as for the distal femur. That is because in proximal tibia resections, the extensor mechanism has to be detached from the tibia. So the patellar tendon has to be cut so that you can deliver the specimen out, and that is what you have to reconstruct. And therefore, these patients generally have relatively weaker extension, and they generally end up having some sort of extensor lag. This boy is doing exceedingly well, but the others may not do as well as what you would see in a distal. Moreover, patient with proximal tibia resection will have to be kept in a splint for 6 weeks. We don't allow the knee flexion so that the extensor mechanism sort of heals itself, and after 6 weeks we start with the knee range of movements and quadricep strength. When it comes to proximal femur, this is a patient with Ewing sarcoma of the proximal femur, which has, you can see already a very bad open biopsy scar here, but he thankfully could be salvaged. He responded well to chemotherapy, a proper wide excision of the proximal femur, and a reconstruction with a bipolar mega process was done. So again, this kind of having active SLR may not happen with all these patients. As you can see in this, all the attachments of the proximal femur has to be removed so that the specimen comes out and your muscles don't really repair to the implant. But if you repair all the muscles to each other, they do get decent control over the hip. Their function will not be comparable to those of a total hip replacement following your standard hip replacement. When the disease involves the diaphysis of the femur, and if the extent of the diaphyseal involvement is extensive, you can even do a total femur replacement. So this modular implant gives you that freedom of replacing the distal femur, proximal tibia, proximal femur, or the entire femur. This girl has undergone a total femur replacement for osteosarcoma of the femur. Now, sometimes what happens, the disease involves only the diaphyses. And honestly speaking, you really don't want to replace the joints if you can save them. In selected situations where you can do that, these are called as intercalary resections. So specifically, this is for diaphyseal tumors, where the articular ends are free of disease, and you can preserve basically a fair segment of these ends of the bone. So this procedure aims to preserve uninvolved joints, and these patients really have a superior functional outcome. This is a patient with a diaphyseal uh, malignant disease. So this is a disease segment. You take adequate margin on either side. You preserve the healthy articular ends of bone on both sides and do a reconstruction. Now there are various ways in which you can reconstruct this gap. You could use an intercalary prosthesis. This is a very rarely used implant. Honestly, we wouldn't really advocate this. This is just an example of what all is available. I'm not even sure whether this is available anymore. Personally, I wouldn't choose this, but there are a lot of other ways in which you can do this intercalary resection, reconstruction. So that is the patient with the intercalary processes. Alternative intercalary reconstruction options are now in this case, where the extent of bony involvement is huge. The reconstruction has been done with a nail plate cement spacer. You can see there are two long nails and a large plate, and holding on to just the fragment of articular end on both sides. What is most preferred now with us is a biological reconstruction. How we can do that? There are again different ways of doing this. This is a patient with a malignant disease in the proximal tibia metatarsal junction, where a segmental resection was done and reconstruction was done with autofibula graft from the same limb. So you preserve the joint here. Here, a heaving sarcoma of the diaphysis of femur was resected and subjected to extracorporeal treatment. This extracorporeal treatment can be done either with radiotherapy, which was always the standard. Nowadays, we also use cryotherapy to do this extracorporeal treatment, and you re-implant that bone to fill that skeletal defect. And over a period of time, both the osteotomy sites will heal, and this is it's like restoring the bone back to its original skeletal integrity. In the tibia, you can do what is called as stabilization of fibula. Tibia in the leg, we have a spare bone just adjacent to the tibia. So you, especially in well-selected cases, of course, where you can get adequate margin on either side, you can resect the segment of tibia. In the patient with osteosarcoma of the tibia, segmental resection, which has been reconstructed with the adjacent fibula, which has been shifted in to fill this defect. So it is like a live graft without the use of microvascular surgery. Rarely we may do arthrodesis. Again, I am not too much of a advocate for arthrodesis because I feel it is an extremely disabling procedure for the patient. But in selected cases where you probably don't have any other option, you can consider arthrodesis. Again, the skeletal defect you can fill with a nail cement spacer with a fibula graft, non-vascularized or vascularized. You could use a allograft and so on. You could use your imagination basically, and you can do the fixation either with the plate or with a long nail or with an interlock nail or with a nail and a plate. The patient with GCT of the distal femur, where a resection and arthrodesis with fibula graft was done. So this is a lady. As you can see, she walks very well, but the real problem is when they are sitting and when they are uh, working. In that situation, this straight limb can be quite a bother. When it comes to ankle and foot, this is a patient with distal tibia osteosarcoma, which has been resected and reconstructed again with the adjacent fibula. So this is a form of tibulation of fibula with ankle fusion. So here the ankle has been fused because the articular end of the tibia has to be removed. And you can see over a period of time, it has hypertrophied beautifully and healed so well. And this patient has excellent function. You may notice that there is some amount of shortening. A lot of these procedures could end up giving us that. but is independent and ambulant. This is a lady who had got a large giant cell tumor of the talus, which was resected, and a tibiocalcaneal fusion was done with a supracondylar nail. I couldn't get a anti-fusion nail for her, but a supracondylar nail worked very well for her. Now, the real challenge for us when it comes to skeletal reconstruction is children, because they are skeletally immature, and skeletally immature means one thing is their bone sizes are small, and the other thing is they have still a lot of growth left. In such situations, we can use what is called as an expandable megaprocesses. You can see this is a type of megaprocesses called as invasive expandable megaprocesses, where you can see you have to physically turn a screw to expand this. So this thing is implanted, and say at 3 monthly interval, we would take this patient into the operation theater and locate that screw and turn it to a fixed number of turns to lengthen this device. So you can imagine this patient has to undergo repeated surgical procedures for lengthening, which is not really desirable. In such situations, if you want to avoid that, you can use what is called as a non-invasive expandable implant, which is expanded through an external device. This is some sort of coil which uses to expand this implant. There are other mechanisms of expansion also. So this is the coil through which the lengthening is done in the OPD outpatients without any form of anesthesia. The only problem with these devices are they are terribly expensive. This non-invasive expandable probably costs somewhere around 25 to 30 lakhs, and it is really not an option for most of our patients. Now, when it comes to that, if that is not an option, what do you do? In such situations, rotation plasty can be a sort of a compromised salvage procedure. This allows the ankle to substitute as a knee after 180-degree rotation of the limb following resection. So this is a patient with osteosarcoma of the proximal tibia, where the entire segment of limb except the blood vessel and the nerves have been removed. There is only neurovascular continuity between the foot part and the thigh part. And then it is rotated 180 degrees, and the femur and the tibia are fused with a plate. So there is shortening, rotation, and osteosynthesis. How do they walk? You use a external processes in that for them to function. So this is how it fits. And this ankle will now power it like the knee. And these patients function remarkably well, as you will see in this video, which was shot by one of our old patients at his home. It's disfiguring, but the kind of independence and function it provides is really remarkable. This is what was done for him. He had really a small segment of proximal femur left, so therefore a DHS was used for fixation. You can see he is able to power his knee, he is able to actively extend it against gravity. He is able to climb stairs on his own. He is able to squat, to all his activities of daily living on his own. In a lot of ways, the functions that this gives may be even superior to a megaprocessors, because in megaprocessors, we really advise them to limit their lifestyle activities so that it prolongs the life of the implant. Whereas here, the sky is the limit. Our acceptance of this procedure is not so great outside institute, but I will be very happy to do this procedure if in a deserving patient, the patient is willing to accept it. When it comes to pelvic bone tumors, again, this is a very complex location and a very complex subject. Just to enumerate, what we do, it is basically divided into diseases which involve the acetabulum, and diseases which are above the acetabulum, and diseases which are below the acetabulum, or covering more than one of these regions. Like in this case, you see this is an Ewing sarcoma of the pelvis, which is affecting the supraacetabular part of the pelvis, which after chemotherapy, once the disease regresses, becomes extremely resectable. Since the acetabulum is not affected here, there is no real need for reconstruction. So it was an excision on the procedure. So this patient, although yes, it doesn't walk great, but she's still walking without support, which is remarkable for a disease which is involving the pelvis. Similarly, this patient who has chondrosarcoma of the acetabulum and intraacetabular region. Now, whenever the acetabulum is affected, it makes your reconstruction really challenging. There are a lot of ways to deal with it. It is a completely different subject. In this particular case, this is what we used to do long time ago. Here, iliofemoral fusion was done. Nowadays, we don't do fusion. We use a Tolene mesh to do mesh plasty. In selected cases, we may even do ECRT of the pelvis, and very rarely we may use a megaprosthesis. Although I personally am not advocate for such devices, but we rarely or probably never do fusions anymore. These are probably those last patients we ever done. This is a patient who has undergone a type 1+2 resection where the supraacetabular part and the acetabulum was affected, and here what was done was an ischiofemoral fusion. Now we come to the upper limb. The lower limb is always far more challenging than the upper limb, because in lower limb, it is a load-bearing bone, load-bearing joint, and secondly, limb length matching is extremely important in the lower limb. Whereas upper limb is there that way quite forgiving, because you really don't have to bother too much about limb length matching, and the load-bearing is not there. Now here, this is a patient with scapular chondrosarcoma. Scapula is one of those few bones, scapula, clavicle, distal ulna, proximal radius, and proximal fibula, where you probably don't need to do any sort of reconstruction. Now here, it is just a complete scapular resection. The only problem with total scapulectomy is these patients lose control over the shoulder. They basically have almost like a flared shoulder. This is a patient with proximal humerus osteosarcoma, where a wide excision and reconstruction has been done with a megaprosthesis. As you see, this is a custom-made implant. This is a very old X-ray and an old case. Again, these patients lose all shoulder function. In very well-selected cases nowadays, where the disease is purely intraosseous or you're dealing with a benign disease, you could use a reverse shoulder megaprosthesis. Those implants are available where you can have quite good level of shoulder function. But your case selection has to be good. You should be able to preserve the entire deltoid muscle and the axillary nerve. Then only you can do a meaningful reverse shoulder reconstruction, which will have function. Where you are going to lose your deltoid muscle, where you are going to lose your axillary nerve, doing reverse shoulder will not restore function. In distal humerus disease, this is a patient with metastatic malignant melanoma with pathological fracture. You could do a resection and reconstruction with a total elbow replacement megaprosthesis. So this is a palliative procedure for this lady. When it involves the entire humerus, where you can see there are skip lesions of osteosarcoma in this patient, you could do a total humerus reconstruction. Now, selected cases where, say, this is a patient with chondrosarcoma of the proximal 3/4 of the humerus, I say a very short segment of the distal humerus could be preserved. That is very tempting to say that, because that would preserve the elbow joint. Otherwise, we could do a total humerus replacement here, but the biological joint is always far superior to any sort of artificial joint. So in this case, I decided to preserve the distal humerus, and the reconstruction was done with a nail and a plate, as you can see here, which was entirely covered with bone cement. So this is a nail plate cement reconstruction for almost a subtotal humerus excision. Now, when it comes to distal radius, this is one of those common locations for bone tumor, typically giant cell tumor. You can see here a large destructive lesion in the distal radius, where the challenge is about reconstruction. Now here, one option is to do a centralization of the ulna. The problem with centralization of the ulna is it is a very easy, simple and effective reconstruction, but the patient will lose other than losing the wrist movement, this patient will also lose the pronosupination, which is a very important movement for optimal use of the forearm and hand. So to offset that, what we now do is translocation or translation of the distal ulna. So you osteotomize the distal ulna and you shift it to fill the defect of the radius and do a fixation. So you do a wrist fusion with that. As you can see in this post-op X-ray, the distal ulna is missing. So it has been osteotomized and shifted to fill this defect. So you really have a localized vascularized graft. And the beauty of this procedure is it gives a very good forearm and hand function. You can see this lady can supinate and eat food and comb her hair or wear her clothes, and she can pronate and cook or write or do all on table activities. And because of the wrist fusion, the reconstruction is very, very solid. So to summarize, when it comes to limb salvage surgery for tumors of extremities, we have two major goals. One is the oncologic goal, the other is the functional goal. When it comes to sarcomas, the oncologic goal takes precedence over functional goals. So you should never compromise your oncologic resection to preserve function. So your primary goal is to achieve adequate margin. And following that, you see how much function you can restore in this salvage extremity. Okay. So these are two major sections of limb salvage, that is resection and reconstruction. However, when you have these kind of situation, so when a patient comes to you, it is not mandatory that you have to save every limb. Just because you are an orthopedic oncosurgeon or a limb preserving surgeon doesn't obligate you to save every limb. You have to select your cases well. In patients like this who are presented late, amputation is definitely a procedure that you have to keep in mind. So wherever you feel your oncology goal is going to get compromised for limb salvage, you should go for amputation. Thank you.
Yeah, thank you very much, Dr. Chetan, for an excellent presentation. I think it was a very comprehensive presentation to cover each and every aspect of a limb salvage, like from upper limb to lower limb, from intercalary to intra-articular. I know it's a very big topic, and it's very challenging to cover all that in one presentation.
Yeah.
So most important thing, like what I just want to summarize this presentation by what Dr. Chetan has summarized is oncological safety. I think the most important thing is we need to get a good oncological margin in any limb salvage. If you're not getting that, then the ablative surgery is always an option, because then still you can offer a cure to a patient by getting a good oncological clearance. So limb salvage, yes, almost 90% of patients will get, but other 10% patients can also be survivor if you are not able to do limb salvage. So not able to do limb salvage is not the end to a patient, especially in orthopedic oncology. So even that if the tumor is very big, you are not able to do a good limb salvage, not safe, then my suggestion is not to attempt a limb salvage. You should be very clear about your principles, which Jagan has stated. And second most important principle, which we should be aware, is about the gap between the neoadjuvant therapy and the need for adjuvant therapy in performing a limb salvage, in choosing your reconstruction. This should not happen that you are planning a prosthesis, you are waiting for a prosthesis, it is coming, it will come after 6 weeks and you keep waiting for that prosthesis. So there is an adequate gap, because otherwise your oncological outcomes suffer. So ideally, we should not be delaying a chemotherapy between 2 cycles of more than 6 weeks. So if we are planning a surgery, we should be aware, like today patient has received the last chemotherapy, we should be planning and 3.5 weeks from last cycle, and then the next chemotherapy should resume within 2 to 3 weeks. If you are not able to do so, my suggestion is to send the patient back to a medical oncologist to get one more cycle of chemo, because even if you do a beautiful limb salvage, you do not follow the oncological principles well, your patient is going to get a relapse and everything is going to fail. Second, other important thing is you have to choose a reconstruction where it can tolerate the adjuvant therapy. Suppose you are choosing a biological reconstruction in an Ewing sarcoma, you should be aware that if the patient requires an adjuvant radiation, your reconstruction is not going to fail. It should allow for an early rehabilitation. So all these factors are to be considered when we are choosing a limb salvage surgery or the type of prosthesis or a type of reconstruction that we are putting. Dr. Chetan has shown many reconstruction options, but I think it is individualized depending upon the type of tumor, the disease, the age of the patient, the surgical expertise, the socioeconomic status, and many other factors which comes to play. So it is not like we need to put a prosthesis there. It is like we need to give them an appropriate function and more importantly, an oncological outcome, which is a survival. Okay.
Yeah, I
so-
think, to summarize, we are oncologists, and I think we should always remember that life salvage is supreme, limb salvage is secondary. So our responsibility when the patient comes to us is to safeguard his life. A lot of times from himself, because nobody wants an amputation, nobody wants a disfiguring or an ablative procedure, nobody wants a function compromising procedure. But we should not succumb to the patient's expectations. Our job is not to make the patient happy, our job is to make them healthy.
Agree. So with this, like I have only few cases to discuss, and these are very straightforward cases because we know that like our audience, we are like we have residents here. So we'll be discussing these few cases to understand the principles of limb salvage. And can you see my slides? No,
Not yet.
not yet. No, just a second. Yeah. So I'll share screen. Yeah. So yeah, can you see now?
Yes, yes.
So I'll be sharing like whatever has been discussed. The reconstruction options will be similar, but we just want to understand like why this reconstruction was chosen among the other options, and what is the impact on the ultimate outcome of the patient. So we'll be discussing few cases in that. The first case is an 11-year-old female, osteosarcoma of lower end of femur, non-metastatic patient that received 4 cycles of chemotherapy. So these are her imaging. So I'll start with Dr. Jaimin first. Dr. Jaimin, you are there.
Yes.
So Dr. Jaimin, what are your concerns in this case? Like obviously every patient wants a limb salvage. So what are your concerns in this patient, 11-year-old female, a standard osteosarcoma of lower end femur?
So obviously the main goal should be a limb salvage surgery, and as the previous speakers have told us that whenever you want to attempt a limb salvage surgery, you should be able to give a good functional limb. So
Yeah.
I will need to see the MRI scans post chemotherapy just to see whether
These are the post chemo scans, Dr. Jaimin. Yeah.
So as you can see here, we can definitely save the neurovascular bundle. They are quite
Great.
we can achieve good margin error at vessels, and we can get the tumor out with a good functional muscle balance remaining, and then we can reconstruct with a standard distal femur. But here the options are, because the age is 11, obviously she will be ending up in a little bit of limb length discrepancy. So we need to calculate what will be the limb length, but at 11 years we don't expect it to be that much. So one of the options is we can lengthen intraoperatively by maximum of 1 centimeter just to compensate the future limb length discrepancy.
Okay. So Dr. Jaimin, you mean to say more or less the limb salvage is feasible. The only concern will be a future limb length discrepancy.
Yes.
So Rudra, any other points or what? Anything else you want to do? You don't want to put a mega prosthesis. You want to do something else?
The other option in this patient would be we can do a rotation plasty also, sir. But I think for an 11-year-old female child in which the growth remaining is not that much, and we can achieve some intraop lengthening by using a routine prosthesis, I would urge towards using a mega prosthesis rather than going ahead with the rotation plasty. So these are the two options that we can do for this patient.
So how are you going to counsel the patient, Rudra? Like, because she is young, she is 11. Okay, the one is the growth remaining, that is an important aspect. Okay, the second is the longevity of a prosthesis. So what all is important in your counseling at 11 years of age?
So for the mega process, if we have to explain the pros and cons of both the procedure to the patient while taking the call, sir. If she's a female patient, obviously the disfigurement will be of a concern to the patient. So they will be more reluctant in choosing this rotation plasty reconstruction modality. But we can explain that the advantages of a rotation plasty is that it is a one-time procedure. The margins can be better. and the outcomes of almost functionally comparable, and also a relatively cheaper procedure as compared to using a mega processes. But I will at the same time also explain about the advantages of mega processes, that the limb will be cosmetically looking better, and it will be having a good same again as a good functional outcome. And but the disadvantages will be that the patient will be requiring multiple revisions in the lifetime, and also there will be a chance of limb discrepancy.
So yeah, so Dr. Zishan, like if you want to choose a mega prosthesis here in this 11-year-old girl, so like what best you can do to improve the longevity of the prosthesis, one, and second, to get the best to reduce the limb length discrepancy.
So Manish, my concern here is if we look at the axial sections, the tumor volume is quite significant. So I would expect some lack of extension or weakness of extension. So I would be worried and prepared before the operation in case a significant proportion of my quads are sacrificed, which will be, I might have to consider some tendon transfers, from the posterior compartment to augment the extension. So that's one bit. The other bit is obviously with the advent of the non-invasive growing implants, I would be more keen towards using those, because every time we do an anniversary extension of the length, we introduce the risk of infection, and hence introducing a 10% risk of amputation every year when we do that.
Exactly.
The other thing we can do, obviously, one of the things we have missed throughout, which I think is very important, is involving the patient, and in this case, the family, in the decision-making process. So in order to manage the limb length discrepancy, your options are either to fuse the growth plate on the other side of the distal femur, or to expand the limb on this side when the patient is disease-free. No matter what we do, obviously this implant will fail at some point and will need multiple revisions if the patient is a survivor. So ultimately, these things need to be put in front of the patient before any decision that we make. Now, I know some people, particularly in some of the European countries, put in uncemented implants in order to say that reduces the risk of aseptic loosening, although the evidence for this is not very clear. However, with HA-coated collars and now with the endosteal collars, the results are quite impressive, although in the very early stages, to reduce the risk of aseptic loosening. Because if you reduce that and exclude infection and recurrence or fracture of the implant, hopefully that implant should survive for a very long time.
So yeah, thank you, Dishan, for covering most relevant points. So Dr. Chetan, at 11 years, if we are planning a standard mega prosthesis, suppose we are thinking of that Indian design that you have shown versus the best possible rotating platform, what is the expected survival? What are we going to counsel the patient? What is the expected implant survival? So is Dr. Chetan around?
Yeah, I'm here.
Yeah, sir. Yeah, please.
Right.
So we need to counsel the patient when we need to have a family in the discussion, as Dishan has pointed, because they should be completely aware of what we are going. We can do a limb salvage that is easy.
Yes,
but
this is
what is going to happen to this limb salvage is
exactly,
what is the question here.
Exactly. This is a very difficult decision making. In fact, I think more than the resection and reconstruction, taking the right decision is very, very critical here. And I think it is really up to us to put all the cards on the table. And I feel, as Dr. Zishan has rightly said, the family and the patient, of course, she's 11-year-old. We can't really, involve her in the decision-making process, but the family should be well aware and well informed about which direction everything will go. The picture of using, makeup process is very rosy to begin with, but we know in long term it definitely extracts the cost from the patient in a lot of ways. So my concern is about longevity of these implants, And as you see, this is just a 11-year-old. We really don't want a joint replacement in a 11-year-old, something that is reserved for the elderly or somebody over the age of 50 or even above the age of 60. With one
Yeah.
of the concerns being limb length issues, the other is about the functional limitation that this will bring into this patient's life. Because to prolong the life of the implant, one of the instructions that I always give to these patients is to be very, very aware of using this limb so that you prolong the life of the limb. Besides just about activity and the biomechanical or whatever you say, the engineering of the device, the other things that can really shorten the life of this reconstruction is aseptic loosening and infection. All that is can put a spanner in the works and complicate matters for us. So all these facts will have to be laid in front of the patient, and especially if the patient is financially challenged, it is our responsibility to bring all these things to the fore, because I see a lot of patients who have been operated, 8 years, 10 years ago with, loose or what you say, the damaged implants coming, and now really they are cured of their disease, but they are now a victim of their treatment, and they are
Yeah.
still patients. It is really unfortunate in the prime of their life. Like this girl, if she is survivor at the age of 20, she will probably be needing some sort of reconstruction, if not before that. And that is really a terrible situation. So I would
Yeah.
strongly advise, if they are going for an implant, to use a good quality rotating hinge imported implant. I'm not too
Yeah.
much in favor of an expandable device if we can avoid it, because again, at some point, it will need a revision, because these expandable implants are generally weaker than the standard implants. And the recommendation is, once your expansion is over, they have to be replaced with a complete implant.
So very nicely covered, Dr. Chetan. Exactly, this was the discussion when this patient presented to me. Actually, she was the daughter of the two medical doctors, practicing
Okay.
medical doctors at Himachal. So when they
Right.
came to me, these were the main concerns. First thing was the expected limb length discrepancy, which we thought we'll manage with doing a contralateral epiphysio. This is
Correct.
timely. But the second important thing was whether to choose an expandable, invasive versus non-invasive versus the conventional mega prosthesis, which we know has a good life, because now we have certain designs which can prevent an aseptic loosening, can have bone
Right.
incorporation, and have a rotating platform, which will not be there in good expandable or especially the Indian expandable design. Where
Absolutely.
so so all this discussion we did, and I always discuss the option of rotation plasty, because if she is a survivor, she has to live with this implant or whatever we are doing for next 60 years. So we
Correct.
need to be the family needs to be aware of what they are getting into it. Okay,
Absolutely.
so all that was discussed. They choose a limb salvage. So I strongly counsel, and as Dr. Jamin has pointed, we planned for an intraoperative lengthening of by a centimeter. So this is what was done: a standard rotating platform mega prosthesis, which has a hydroxyapatite collar, which allows for a bone in growth. And this is the best that you can do to improve the longevity of the implant. Give a rotating platform, do tendon transfer or a muscle balancing as Dr. Zishan has advised. Plan for a bone in growth by having an HA coating or a porous coated implants, and do a timely FIVO that can give you a good prosthetic life, maybe I think between 15 to 20 years.
Correct.
But we need to counsel, and most importantly, I think the decision rests with the family, then with the surgeon. But yes, definitely the limb salvage was feasible, and that was done. And this was the patient at 4 years follow-up. So she is fine. She is happy as of now. Now she is
Yeah.
16. She is doing cycling. She is able to do participate in most of the activities. But yes, there are some concerns regarding the participating in running or jumping
It
kind of
worries
activity.
me. Yeah, it worries me.
Yeah. So, but we cannot stop kids. So they are still,
Absolutely.
yeah,
Absolutely. They have a life.
they have a
You have to
life. They
let
have
them
to
live.
participate. So that is what was done. So let's move to the second case, which was a 10-year-old male with swelling in the leg for 4 months. So these were the X-rays, and these are the initial MRIs. So it was a non-metastatic osteosarcoma of the proximal tibia in a 10-year-old male child. So my question is to now Dr. Zishan again. Zishan, so how do you want to manage this? These are the post-chemotherapy imaging. osteosarcoma, non-metastatic, now almost the same age group. But yes, the epiphysis looks uninvolved.
Yes, so Manish, patients had a good post-chemo response.
Yeah.
And looking
And so,
looking
sorry
at this,
sorry to make you speak a lot, Zishan. I know you are having, you
That's
want to give
okay.
voice rest, but I
That's
have to
all right.
ask. Yeah.
So looking at it, the growth plate seems to be non-involved. And as
Yeah.
one of our first speakers said, so in this scenario, we will use the growth plate as our anatomically safe barrier or safe margin. And
Great.
we'll sort of do an intercalary resection. And what we can do then is on the x-rays that we can see the bone quality looks quite good. So we can recycle this bone in whatever technique is available and replant that either on its own, or we can put in fibula as a hot dog. That is one option. The other option is we can use the same sided fibula in form of tibialization or as in double barrel. So in this instance, I would be erring more towards biological reconstruction.
Great. So basically, you want to use physis as a barrier, do a joint sparing intercalary resection,
Correct.
and do one of the biological reconstruction.
Absolutely.
Yeah,
Absolutely.
Rudra, any different thoughts? You have a huge experience with pedicle cryotherapy. So do you want to try that here?
Yes, sir. So as Dr. Jishan said, we will be erring towards a biological reconstruction here because the patient will not be requiring a post-op RT. So we can go ahead with the reconstruction of which is biological in nature. The bone stock is good. And I can see a good distal bone stock, which will be having even after getting a margin. So I would err towards doing a pedicle cryo with this patient and then subsequent reconstruction. So my call will be
So-
pedicle cryo.
So can you just describe the steps of pedicle cryo here for everyone to learn? Like how do you going to do a pedicle cryotherapy?
Yeah, sure.
Sorry,
sir.
I don't have
So-
yeah.
Yeah, so the resection part will be same as the tumor resection of other surgeries. We will be excising the tumor with a good enough margin all around. The physis will be taken as the uppermost margin, and distally, depending on the MRI, we will be taking a segment of bone till which the disease, and we'll take a margin from there, and beyond that, we'll expose for at least 5 centimeter, depending on the build of the patient, to expose the bone more. We'll take a fibular osteotomy at that level, and then we'll take out the whole bone away from the body. We'll separate this specimen from the rest of the body with a separate draping, and then we'll excise the soft tissue component of the tumor, which is outside. After that, we'll dip this bone into liquid nitrogen for 20 minutes, followed by thawing in room air for 15 minutes, followed by dipping in a sterile water, which is mixed in vancomycin for 15 minutes. After that, we will reduce the bone back into its place, and we'll use appropriate plates for the fixation into its place.
Rudra, one thing that you didn't tell our residents is
Medial
what are you going
gastroclep.
to do? No, that is fine. What you are going to do about the patellar tendon for leg extension?
Okay, so we'll have to reconstruct it, sir. We'll have to reattach it back to the bone with the help of maybe suture anchors, or maybe if you want sutures back into its place. We can use the help of a medial gastroclep for the same.
Yeah, agree. So, Dr. Jamin, like you want to do the similar procedure, or you want to do something else? You also have a huge experience in intercalary section. How do you want to plan your cuts? Because Dr. Zishan has said that the physis is a good barrier here. So, do you want to take the cut whole through the epiphysis, or you would like to save some of the metaphysis here?
Yes, obviously, as you can see, some of the metaphysis is still spared, but obviously need to compare pre-chemo, post-chemo, T2 images. You need to be absolutely sure that I think medial part of that metaphysis is completely free of the disease. And then now you have a lot of lateral part, yes, lateral. So you have a lot of fancy things now available. You can customize a zig for this patient. You can use an intra-op navigation if you have, but as easier as it is, you can use your IITV guidance just to pass a K-wire through that physis and take a cut above that wires, to insert 2 parallel K-wires, and then guide your cut just above that K-wires, and then take a cut. So that could be the one option. But anybody of the panel interested in using a joint sparing intercalary expandable process here?
Not me.
So
I've had no experience.
yeah, so joint
Not me.
sparing
I
intercalary.
think-
Just a thought.
No,
So
I think
it
where
will
you
be-
can do biological, I think, using an implant, I'm not too sure how wise that is.
And
I
plus
would
your
agree,
cut,
your personal bone is for life.
Yes.
yeah, and your cut in the proximal medial part here will be just above the physial cartilage. So you will have a very thin bone of epiphysis for you to prosthesis to get a hold of. So that will be very challenging here.
Yeah, this
So
is,
my-
it is easier said than done. It is not
Yes, yes.
as easy as it is made out to be. And moreover,
Yes,
here
yes.
we are really playing very close to the disease. So, this is something which has to be thought out very, very well. Your cuts have to be really, really precise. You have to ensure that you don't cross the growth plate into the disease because it's just across that thin layer of cartilage.
So, Dr. Jagan,
Yes, yes.
like you have already actually told us the principles and the physis as a barrier. So in this case, like we know that the disease is abutting on the medial side, laterally we have some spared bone.
Yes.
So would you like to have a complete barrier of a physis, or you can actually want to save some part of the bone on the metaphysis?
Sir, on the lateral side, since there is some normal metaphyseal bone, on the lateral side, we can actually, the cut can be a little distal to the physis. This is what I think. So in order to get better fixation. And on the medial side.
But
since
will it
is-
not be very risky, Jagan? And second thing is, like, will you require a navigation or some 3D cut? Because it's the three-dimensional structure, the bone. So it will be very challenging for you to get that cut. So will it be possible under CM guidance, or you require a navigation or a 3D digs for that?
So I have no personal experience with navigation as such, but I think so it will be possible under image intensifier if we plan it carefully on the MRI.
Yeah, so more or less in tibia and in lower end femur, we are able to take good cuts even with an image guidance in both AP and lateral views, and we can put 2 K wires in coronal planes and take the cuts above that. That was done almost like what our panel has described. Almost a similar thing was done here. So we put 2 K wires parallel to each other, and then we started the cut above that K wire, and you can see on the lowest most image that we were having only 2 to 3 millimeter of the epiphysis on the medial side, which was spared, which was left actually. And once we have completed the cut almost till the 2/3 of the medial side, then I removed the wires and then I entered the physial cartilage there. I still took physis at a margin, but then the cut was through the physial cartilage rather than through the epiphysis. So with that, I was able to save the lateral 1/3 of the full epiphysis, while on medial side, it was only the 2 millimeter. So it is very important because on the medial side, the tumor is touching the physis. So if you take a cut through the physis, you can be marginal or you can be intralesional. So you have to go above the physis. But yes, on the lateral side, tumor was not touching the physial cartilage. So physis can act as a barrier and we can go through the physis. So this is how the cut was completed, and we have used the recycling of tumor bone, in this case by an extracorporeal radiation. Use a gastroc flap, as Dr. Rudra has described, suture the patellar tendon to the gastroc flap, and use 2 plates for reconstruction. And this was the final function, and the patient at 5 months follow-up, having a good knee range of movement, no extension lag, and patient walking partial weight bearing at that moment. So basically, to understand, like, we can do a recycling of tumor bone when the bone stock is good. So Dr. Chetan, my question is, suppose this bone was very lytic and still the salvage was feasible, what would you have offered to this patient?
You mean to say an intercalary resection?
Yeah, because the intercalary was feasible,
bone,
but the bone quality was not. Suppose the
bone
bone quality is
was
bad.
correct,
So
correct,
how will
correct.
you manage that situation?
Yeah, now here, where Jamin was introducing the idea of expandable intercalary prosthesis. That is an option that can be considered, but then it will have to be custom made for this particular patient because your cards and everything will have to be matched very well. That is an option. Other option that I can really think of is plate and cement spacer to fill that defect. Now, how it will work in the long run, we really cannot say, but that is a consideration. And if that is not an option, then rotation plus.
Agree. So, Rudra, any other thoughts?
Yes, sir. My question to you is, sir, actually, this patient is a 10-year-old patient which is having some growth potential left on the proximal tibia. What did you do to address the limb discrepancy that is going to have? Was it epiphysiodesis or were you planning for a lengthening afterwards?
So that is my question rather than your question. You are stealing my question. Anyway, that is fine, Rudra. Now you have asked me, so I have to answer.
Yeah.
So basically, 10 year, we are always concerned about the growth from the proximal tibia, and we need to calculate the growth by using one of the methods. So I'll go back, and I have actually shown this slide, which is the multiplier method, where you need to actually predict the growth remaining, which is equal to the current length of the bone, and M is the multiplier according to the age and sex minus 1. So that will give you the growth remaining of that part of the bone, whether it is tibia or the femur. And according to that proximal or the distal physis, you have to calculate which physial you are losing. And suppose if it is between 2 to 3 centimeters, you're planning an intercalary, you can plan for a contralateral epiphysiodesis. But yes, if it is significant, then the patient becomes very short. The legs becomes very short as compared to the thigh. So in those cases, now we have a good experience with our reconstruction surgeons, iliacal surgeons, where they can gain actually the length by doing a distal osteotomy and doing a lengthening, but that will be done only after 5 to 7 years of treatment completion, when we know that there is no relapse of the disease. So any other thoughts, like if Jagan or Dr. Chetan or Zishan wants to contribute into that?
Sir, and just I want to make one point. Like you said that if the bone is not very, the bone stock is not very good,
yeah,
lot of lysis. I think so.
Yeah.
In my small little experience, what I have seen is that if we augment, especially the recycled bone in tibia, union of the osteotomy is really not an issue. It becomes more of an issue in femur, where we have to augment it with biological method like using a vascular fibula or the Kapana technique. For tibia, in my small experience, what I have seen is that usually the osteotomy sites, they unite over a period of time.
So I think I'll go with what Dr. Zishan has spoken, is using a fibula. If the bone quality is not poor, we can use either ipsilateral fibula or a contralateral free fibula with an allograft, or as Dr. Chetan was describing, that we can use a temporary cement spacer, or maybe counsel a patient for a rotation plasty rather than doing any limb salvage kind of a procedure. So those will be my options. So if there's anything else, otherwise we'll just take one more case and then we can go to the quiz. So next case, next case is now a 3-year-old female, had a history of fall while playing, and patient presented to us with a pathological fracture in the proximal humerus. As you can see in this imaging, there is a periosteal reaction also, which is going a little down. These are the initial CT images. The biopsy was an Ewing sarcoma. PET CT was a localized disease. Patient was started on chemotherapy. So patient had a good clinical response to chemotherapy. So what should be the local treatment plan? These are the MRI images of the patient here. So technically what I can say now is the fracture has united and the tumor is involving the proximal end of the humerus, but it has malunited, and otherwise the response to chemotherapy is quite good. So Dr. Jamin, so what do you want to do in this very small kid, 3 years old, proximal humerus Ewing's, and what are your concerns about your reconstruction? Like how you are going to choose the reconstruction or counsel the family for the reconstruction?
So obviously, as she had responded very good to chemotherapy, so that is a very good sign. And as we all know that in Ewing's, until and unless you can remove the disease, that is the best option that you have. So we'll definitely counsel the patient and the relatives that the best option we have is if we take out the disease and then do reconstruction with whatever physical method we have, that is the best option that they have. Now the type of reconstruction, obviously.
So basically, you want to do the surgical resection of the proximal humerus.
Yes. In this case, yes.
Yes.
So then now reconstruction, obviously, as he's a 3-year-old kid, whatever reconstruction we do, I don't think that will remain for a lifetime. So first and primary thing that we need to counsel is to the parents that she might need revision surgeries later on in her life, and she definitely has to deal with limb length discrepancies. I think with whatever modality that we use.
Yeah. So
and
what modality?
The options that we have, or what I. Yes. So what might I choose is obviously we have done 2 or 3 cases with a vascularized epiphyseal fibula transfer, but none of them have worked. Both of them have failed, and we could not achieve the results that other authors could achieve. But I will still like to use that. In this case, I will just again consult with my plastic surgeon. If they are again comfortable with it, then I will definitely use that option.
What is? Can you describe just briefly what is the procedure, Dr. Jamin?
So in that resection is a standard resection. We have to achieve an R0 resection, and then to reconstruct that part, we take a proximal fibular autograft along with its physis, and that's a vascularized. So we take the fibula with a branch of an anterior tibial artery, which is a main feeder for the growth of that physis, and then we anastomose that with the donor side. But this is very complex procedure, and as I told, I have done 2 cases with my plastic surgeon, and none of them have grown. So I'm very skeptical about using that. But the other option obviously is use a temporary cement spacer over here, and then wait for what happens.
So basically now the proximal humerus contributes almost like 70% of the total humerus growth, or maybe a little more. So our concern is when you are losing a proximal humeral physis, so your main concern is the growth. And because of that, you want to do the vascularized, something which can grow over the time, which definitely a prosthesis will not, because the prosthesis will dislocate rather than growing. So you want to consider a vascularized epiphyseal fibula as one of the reconstruction options. That is what I can get. Yeah. So Rudra, any other thoughts on this?
Yes, sir. As Dr. Jagandeep has already demonstrated in his presentation, that the pathological fracture is not an absolute found indication for limb salvage. So we'll go ahead with the osteoarticular resection of the proximal humerus with the routine margins. And after that, I would urge towards using the nail cement spacer as a reconstructing modality, because the patient had a pathological fracture. So I think the patient will be requiring a post-op radiation in that part. So going ahead with the epiphyseal fibula in the first go is what I will not urge towards. We'll go ahead with the proximal humerus section in a non-biological reconstruction. And later in life, when the patient is a survivor, we can convert it to a epiphyseal fibula, and after the post-op party.
Yeah, great. So Jagan, and you agree with Rudra or Jamin, or you have some different thoughts there?
So I agree with Dr. Rudra, because I will also err on giving the patient a post-operative RT in this case, and I will be a little skeptical using any form of biological reconstruction. So I would rather be using a non-biological method like a nail cement spacer, because the patient will be receiving radiation, because it was a path fracture and it is having sarcoma, young kid. So
that is what exactly, Jagan. So that is what I actually wanted to emphasize here. Is there are multiple reconstruction options which are available, and the best reconstruction option, which Dr. Jamin has pointed, will be something which will grow over the time, which is a vascularized epiphyseal fibula, which definitely will be the best for this kid. But yes, because we need to think about the oncological safety first, and oncological safety here is because of a pathological fracture, even sarcoma, patient definitely needs adjuvant radiation. And that has a significant negative effect on the growth of the vascularized fibula. So because the physis is going to go, it is not going to grow when you add a radiation on a growing physis. So this is a scenario where obviously the best reconstruction option will be a vascularized fibula, which is epiphyseal fibula. But yes, we'll not do that because patient needs an adjuvant radiation. So that is why we also choose a nail spacer gave patient an adjuvant radiation, even if our margins were free, but the necrosis were low. But the main reason for adding a radiation was a pathological fracture. And Dr. Dishan, you agree with this kind of a reconstruction, or you would have done something different?
Agreed, Manish. I mean, it's that same scenario where we say damned if you do and damned if you don't. Some other options that you can use. I've never used a clavicle pro humero. Although if you look at the literature, the maximum amount of complications that one experiences or have been reported.
I have listed all the complications.
But with the vascularized epiphyseal transfers, we've done a few and we've had good response with that. Now, having said that, I mean, we don't use radiotherapy for all Ewing's cases. Yes, in this instance, because it was a pathological fracture, that's a completely separate beast. But your survivorship, obviously, we all know, mainly depends on your post-chemo response. Your radiotherapy is basically just for your local control. So I agree with what you've done. But it's very difficult to decide on the best modality in this age, particularly in a pathological fracture. So suppose I would put in another question to the panel. Let's suppose you had 100% post-chemo response with this patient. Would you then still consider giving them radiotherapy?
So, Dr. Chetan, you want to take that?
Yeah. Now see, the bigger concern here is the age of the patient. He's just 3 years old. At 3 years, we should really think a lot before, also involving radiotherapy in her treatment. And what are the consequences of that? Because it will have a lot of spillage in that territory, and it will probably impact the future growth of that limb. But we have to balance the oncologic goal versus the functional outcome of this patient. So I think really a team has to decide regarding what are the roles of adjuvant treatment in this, and on that basis, decide on what kind of reconstruction we should do. We have no choice but to definitely offer a surgery for resection here. Now, where it comes to 100% necrosis, where the patient has had a pathological fracture, I would be very happy to give radiotherapy, because I feel this is, possibly also going to be very radiosensitive to, treatment. And moreover, what we have seen is patients with 100% necrosis doesn't mean that they don't metastasize or they don't have local recurrence of disease. In fact, some of the most aggressive recurrences I have seen is in patients with 100% necrosis. It also means that it is a very aggressive disease, which is also responding hence to the line of treatment that we offer. So it really is a difficult question to answer, and I think there will be a lot of different answers depending on which place or which institute or which team is treating this patient.
Yeah. So Dr. Chetan, any experience with clavicle pro humero, as Dr. Dishan was?
I have seen only complications during my training at Tata Memorial. In fact, that we gave it up at that time.
So the literature review of clavicle pro humero suggests almost like 70 to 80% complication rate. Exactly. So more or less, it is not done. So I think the vascularized epiphyseal transfer is a much better option.
But again, again that procedure I had never seen. The vascularized epiphyseal. It is, to me, more theoretical than practical, especially in a 3-year-old. You can't imagine what size of vessels
This is what has happened to the kid after end of 5.5 years. She is short by 7 centimeters. So Rudra, what can you do now? Now she is disease free, 5.5 years follow up, shortening of 7 centimeters.
So now we can contemplate a free epiphyseal fibula transfer, sir. But still, I think the age is too less, so we can keep the patient on a follow-up. Maybe when I'll have to take a call. I will have to discuss with the plastic surgery people when is the best age when they can do it. So I don't know whether it's possible at 5.5 years. So
no. Now she's 8.5. She was 3 years to start with. This is 5.5 years follow-up. Now she is 9 almost.
Okay, so if they are able to do it, sir, I will definitely want to go ahead with a free epiphyseal fibula, because there is evidence that there is a bone growth which can happen with the free epiphyseal fibula transfer, and we can address this shortening which is present with the help of that surgery.
At least partly we can address.
Yeah, partly we can, not completely, but partly we can. I will have to counsel the patient and the relative for the same.
Honestly, if you ask me, I wouldn't recommend anything to be done for this patient, because it is like creating possibly a new problem for her. This is post radiotherapy. And honestly, just because we can do something doesn't mean it will offer us exactly what we desire. See, if it grows, I am not even sure whether it will grow. If it grows, do you think the limb will grow or the fibula will grow up and come out of the shoulder? I mean, we really don't know. So I think, especially when it is not a contained bone, uh, I am very, very skeptical.
Agree. So the most important concern is what we are going to do gain. We're doing a vascular epiphyseal. We might gain 1.5
confident.
inches. Yeah, we might gain 1.5 inches, but will that be useful for the patient? No one is sure about that. If
I
the
wonder
patient
whether
is
this
happy,
nail will come out in the first place.
So anyway, so just going through the last case, so I'll just go through it. 4 years male, similar situation, Ewing's proximal humerus, non-metastatic. So have a good response to chemo. We discussed in multidisciplinary meet, not planning for adjuvant radiation. This was the post chemotherapy imaging, and we did a vascularized epiphyseal fibular transfer, and where the plastic surgeon asked to move the anterior tibial artery. So as Dr. Jamin was pointing, it didn't grow. The fibular physis actually got diffused very soon. It didn't grow and it subluxated also. And you can see that ultimately the physis disappeared only. Yes, there is a data which says that the fibular epiphysis can grow, but there is a review article on a vascularized fibular epiphyseal transfer which shows that almost 54% major complication rates after this procedure. Definitely, it has a role in proximal humerus resections in kids, but the exact outcome no one can guarantee. That is the main challenge here. So we can take the further inputs from the panel before I conclude.
So can I ask a question, Manish, from
yes, Ishan.
colleagues? How many of you actually do a fibuloglenoid arthrodesis and utilize the scapulothoracic joint for movements? And what is your experience? Because probably the workhorse of my reconstruction around the shoulder revolves around arthrodesis. We've got reasonably good function. Our patients are getting 80 to 90 degrees of abduction and probably about the similar degrees of forward flexion. Although it looks a very funny kind of reconstruction. One of the senior oncology surgeons in Islamabad used to do this. And initially I used to do a suspension arthroplasty, but over a period of last 4 years or so, I've switched to mostly doing these arthrodesis and they work reasonably well. So I just wanted to know what was the experience of my other colleagues with this.
Dr. Chetan?
No, I have never done a fusion of the shoulder, but I am sure, what you're saying is absolutely right. It would definitely give a more stable shoulder and some range of function at the shoulder because of the scapulothoracic movement. But I think it is not an easy fusion to achieve because of the long lever arm, the thin bones, and the scapula being a flat bone. Yeah, so I am sure it is an extremely challenging procedure.
What we do is apart from obviously just the standard principles, what we also do is osteotomize the lateral end of the acromion and just leave the inferior cortex intact and just flip it down onto it and then augment the arthrodesis with that through a couple of screws. And that makes a huge difference. I know there's a lot of anxiety when you're just putting in 1 or 2 screws through that fibula. The other thing we do is you have to bend that plate in very funny angles because that plate then goes over the acromion or the remaining part of the acromion onto the spine of the scapula. And when you're doing that fixation, you do not feel very comfortable. But what we do is we put them in that aeroplane splint for about 6 weeks after the operation. So far, in about 27 or 28 patients, we've only had 2 patients where there has been a graft fracture, where it has healed. One of them has healed on its own. The other one just needed fixation. None of the cases we've had experiences with metalwork failure or the metalwork coming out. So it's a difficult fixation, I know, but I feel that it provides a more stable joint.
So can I add something?
Yes, Chairman. Yes.
So obviously we all know that we want a stable shoulder, because we are not going to get a shoulder function. We just want a stable shoulder so that our elbow hand can function. So many of the times what happens is our prosthesis, whatever we have inserted, it just pops out within 2, 3 or 4 years. So one of my colleagues just did a case where there was a proximal humerus prosthesis, but which had a glenoid arthrodisc type of a screw, which could put a fused joint. So I like the idea, because that would keep your shoulder as a type of a fused position, and that will not allow it to subluxate. So it's a standard proximal humerus prosthesis with a glenoid component, but it's a fused prosthesis. Means there will be no movement between the shoulder and the glenoid component. There will be a screw going from the humeral prosthesis through glenoid into the glenoid cavity. So
it's like
a short.
It's like an arthrodisc.
Yes. So I think that is a good option if we can explore it.
If I add into that what Dr. Dishan and Jamin has spoken, like my teacher, Dr. Shivendra Singh Gill at PGI Chandigarh, he always used to tell that shoulder is one joint where a painful shoulder, like it is for a normal orthopedic procedures, a painful shoulder, then arthrodisc improves the function.
Yes.
Okay, because when you fuse the shoulder, when you give a patient a stable shoulder, patient gets the scapulothoracic movements and patient gets a good elbow and a hand function. So that is what I think Dr. Dishan wants to emphasize, like having a stable shoulder improves your overall function of the upper limb. But yes, definitely, I think the patient might have some restriction in the rotation, which is not there in the suspension of the fibula. Yeah, so that will be a challenge, because a pronosupination sometimes is very important for day-to-day activities. Yeah, and that is what we want. We usually do with a mesh. We give them a stable shoulder, but allows for a little bit of a pronosupination or a rotations happening at the shoulder. Okay, so that internal external rotation a little bit also helps in patient day-to-day movement. And Dr. Chetan has also shown in some of the videos, I guess. Patient writing with the scapulectomy, because of a stable shoulder, they can still write. But otherwise, it becomes a little challenging when the shoulder is fixed in one position. But yes, a shoulder is one joint where stability is very important, and that actually increases the overall upper limb function. So I think that is where we can conclude here. Yes, but Dr. Dishan, we would like to see your results published sometimes of a shoulder arthrodisc.
Yes.
Yeah, sure. Yeah. So I think with this, we'll conclude and we'll move to the quiz by Dr. Prateek. And thank you very much, Dr. Dishan, Dr. Jagan, Dr. Chetan, Dr. Rudra, and Dr. Jamin for sparing your time. I think we had an excellent session. If there are any other questions, we can take. Otherwise, we'll move to the quiz.
Thanks.
Thank you, Manish. It was a pleasure to participate. Really good fun.
Yes.
Yeah. Thank you all.
Yes.
Thank you, sir.
Thank you.
That was a very enriching discussion and didn't feel like bringing it to a halt. But we are anyways running behind schedule. So
I know, Prateek.
Yeah.
we'll do fast.
No problem, sir. No problem. It was a very good discussion. So I thought even the residents and the delegates will enjoy. So moving on.
Manish, would you mind if I take leave?
Yeah, please, Ishan. Please carry on.
Yeah.
Thank you very much for joining.
Thank you very much,
sir, for your time.
Thank you.
Yeah.
Thank you.
Thank you, sir.
So now we'll move on to the quiz part, that is for the delegates. And as you know, we conduct it over the Kahoot app. So we request all to just join in through the Kahoot app. Now, if Mr. Somnath can share his screen, then we'll just first play the demo quiz and then go on to the main quiz. So the demo quiz is for the residents to get a feel of the game, the delegates and the residents to get a feel of the game. We'll just play 2 sample questions and then we'll move on to the main quiz.
Is my screen visible?
Yes, it's visible. So we'll first play the demo quiz, the ones with the 2 questions.
Practice quiz, right?
Yes. So a note to all the delegates, you need the Kahoot app to play this quiz. And what we have noticed is many a times people use names which are then difficult to identify if you win. So please be careful in using a name to play the quiz in such a way that we can identify the winners later. So maybe use your initials and your place. So let's start with the demo quiz first. So the rules are simple. You have to be quick and you have to be correct. The game pin will be shared. This you have to enter into your Kahoot app. So this is the demo quiz for today, just to show how the game is played. So the game pin is 400-7577. 400-7577. So we have around 26 participants left. So maybe at least half of them can join. And we'll have a good quiz. Now this demo quiz is just to show how the quiz is played. So this doesn't have a winner or a prize money. This is just for your understanding. That's good. We have around 7. We'll just wait till around 14-15 members join in.
We can also join, Pratik?
Yes, sir. You can also join, but you may not get the prize money.
Okay, then it is fine.
We don't mind everyone joining, but the panelists are not eligible for the prize money. The delegates will be getting that. But you can definitely join and participate and see how to compete. So this is the demo quiz. We'll have 2 quiz questions just to show how to play the game.
I think we can start.
Yes. So we have around 10 participants for the demo quiz. So let's start with the demo quiz. Don't worry, the main quiz is after this. This is just to show how the game is played. So who is the Prime Minister of India? Is it option red, Amit Shah, option blue, Draupadi Murmu, option yellow, Narendra Modi, or option green, Rajnath Singh? Prime Minister of India, is it Amit Shah, Draupadi Murmu, Narendra Modi, or Rajnath Singh? This is the demo quiz question number 1. For getting maximum points, you have to be correct and you have to be quick. And the app then calculates the winner from the list. So last 1 second to answer this question. And the correct answer is yellow, Narendra Modi. It's good. Now we go on to the next question of the demo quiz. Which of the following is the national capital of India? Is it red, Mumbai? Is it blue, Kolkata? Is it yellow, New Delhi? Or is it green, Bangalore? National capital of India, Mumbai, Kolkata, New Delhi, or Bangalore? So we had around 10 participants. So we have answered, maybe 1 or 2 more answers to go. Last 10 seconds to answer this. This is the demo quiz question number 2. You have to be correct and you have to be quick to get the maximum points. The correct answer is yellow, New Delhi. So that concludes the demo quiz. And at the end, you will have a leaderboard which will tell us who scored the fastest. Remember, this is the demo quiz, so no prize money for this. Fantastic. Now, congratulations for the winners for understanding the game. Now let's go on to the main quiz. And the main quiz has 10 questions. You'll have 30 seconds for each question. As I mentioned, please use the correct name to play the quiz so that we can identify the winners. we'll just wait for the main quiz to start. So I think the objective of the game is pretty clear. You have to be correct and you have to be quick.
Somnath, share the screen.
There are some issues with the screen sharing. We'll just wait for a couple of minutes. Mr. Somnath?
So just a second, sir. I'll just do that.
Okay. So as I mentioned, please use the appropriate name for the quiz so that you can be eligible for the prize money. And the objective is simple: be quick, be correct. Mr. Somnath will share the screen and we'll have the main quiz pretty soon.
So is my screen visible?
Yes, your screen is visible.
Yes, sir. Once you say, sir, I'll start, sir.
Yeah, start please. Yes, so now this is for the main quiz of today's session. The game pin is being loaded. 9199415. That is the game pin for the main quiz of today. So delegates are requested to enter this into the Kahoot app and we can then go ahead with the main quiz. Again, I can see around 26 participants. So maybe halfway mark we wait, 13 to 14 people to join in. It's good. We have 13 here, 14, brilliant. So the game pin is 9199415. Okay, we just wait for a minute or so more before starting with the main quiz. We have 18 participants till now. This is the game pin for the main quiz of today's session, 9199415. So
it will be interesting. We have more than 20 people now.
Yes, we have 20 participants, so that would be great. So I think, Somnathji, we can start. So the first question of today's quiz for the session on limb salvage surgeries. The classification of margins according to Enneking include all except red intralesional, blue marginal, yellow wide, or green complete. The classification of margins according to Enneking include all except intralesional, marginal, wide, or complete. So which of this is not in the classification? And majority have got it correct. It's green complete. Manish sir, if you can just explain that point.
Yeah. So basically, it is not complete. It is called as a radical margin. We have an intralesional, marginal, wide, and a radical where we do a complete compartmental excision. But that margin is called as a radical margin rather than a complete.
Yes.
Okay. And intralesional margins we do for benign tumors like a GCT.
Great. Okay. Majority of our participants have understood this and have answered correctly. Moving on to the next question. Question number 2. The various methods of bone sterilization include the following except red cryotherapy, blue ECRT, yellow microwave therapy, or green pasteurization. Which of the following is not a method of bone sterilization? Cryotherapy, ECRT, microwave therapy, or pasteurization? And there is a difference between two answers, between microwave and pasteurization, but the correct answer is microwave therapy. Manish sir, if you can just explain that.
So basically, as far as the bone architecture preservation is concerned, the cryotherapy is the best because when we use a liquid nitrogen, it preserves the bone architecture best. Following which is the ECRT, which is an extracorporeal radiation therapy. We can use two other methods of recycling of bone. One is the pasteurization and the other is autoclaving. But both are inferior to cryo and ECRT because they destroy the basic bone architecture much more. So more or less, they are not preferred method, but yes, people have tried pasteurization and autoclaving, but never a microwave therapy. So the answer here is microwave.
Microwave. So basically, this is the same bone which is treated and then used again. So we have two questions down. Moving on to the next question. And Mr. Barry is leading the scoreboard as of now. The amount of radiation dose given during extracorporeal radiotherapy is red 40 gray, blue 50 gray, yellow 60 gray, or is it green 70 gray? The amount of radiation dose given during ECRT is 40, 50, 60, or 70. And the majority have got it correct. It's 50 gray.
Yeah.
Yes, sir.
So yeah, basically what happened is like people have started with almost like 300 gray single fraction, and then they have actually started coming down to see the best safe dose, which is the minimal dose which can still have a tumor kill, and which they found out to be a 50 gray in a single fraction. So people have used a higher doses, but now more or less all the institute prefers a 50 gray in a single fraction as a radiation dose for extracorporeal radiation.
Yes. So now let's move on to the next question. Can we have a look at the scoreboard after 3 questions? So Lesinsia has come up to the first position, followed by Saravna and Ram. We still have 7 questions to go, so buckle up, people, and we can still have a change in the leaderboard. Moving on to the next question. The 4th question of today's quiz. The order of steps during cryotherapy is it red, freeze, thaw, curette, wash in saline? Is it blue, freeze, thaw, wash in saline, and then curette? Is it yellow, curette, freeze, thaw, and then wash in saline? Or is it green, curette, wash in saline, freeze, and thaw? So these are the steps in cryotherapy. Which are the correct order of these steps? Your last 3 seconds to answer this. 2, 1. And we have a mix of answers, but the correct answer is curette, freeze, thaw, and wash in saline. So Manish sir, if you can explain that.
So basically we need to curate out the material for the liquid nitrogen to go and have a uniform expansion. So that is why we try to do a curate in a separate trolley first. So that, and we sometimes require a little bit of drilling also to open the medullary canal, so that the cryotherapy, when we are actually in a thaw phase, there is a uniform expansion of the bone. Otherwise, there is a risk of fracture is there. So we always curate the marrow, then put it in a cryotherapy.
And then we freeze, or I think Dr. Rudra had mentioned the steps.
Dr. Rudra has already mentioned the rest of the stuff. We thaw in a room temperature and then we put in a normal saline.
Yes. So that was an interesting question. Moving on to the next one. The 5th question. Mohs surgery is used for? Is it red, bone cancer? Is it blue, soft tissue cancer? Is it yellow, skin cancer? Or is it green, metastatic cancer? Mohs surgery is used for red, bone cancer, blue, soft tissue cancer, yellow, skin cancer, or is it green, metastatic cancer? Last 5 seconds to answer this. And the correct answer is skin cancer.
I think more or less people have answered it correctly. Most microscopic surgery is where we keep identifying the margin and keep rejecting accordingly. It is done for the skin basal cell carcinomas or squamous carcinomas.
Yes, so it is used for skin cancers. Moving on to the next question. There's a lot of change in the leaderboard. Lesinsia is still leading, followed by Saravna and Ram. Others have still 5 more questions to go to catch up to the leaderboard. Let's go on to the next question, the 6th question of this quiz. Canada's technique is a technique of giving chemotherapy, a technique to deliver radiotherapy, facial distraction to resect metaphyseal tumors, or is it green technique which uses live fibula to fill a defect? Canada's technique is red technique of giving chemotherapy, blue technique to deliver radiotherapy, yellow facial distraction to resect metaphyseal tumors, or green technique which uses live fibula to fill a defect. And people are confused between two answers, yellow and green. The correct is the yellow one, and Dr. Manish will give us an explanation for that.
Yeah, so basically, like the case I have shown where the tumor was abutting the physis, we can use a Canadal technique also, where we put an XML filter, distract the physis before taking a cut through the physis. So it is a physial dissection to resect a metaphyseal tumor.
Yes. There is a technique which uses live fibula. I think that is the Kapana technique, which also uses the allograft and the live fibula. So that is different from Canadans. So moving on to the next question. Saravana has moved up the leaderboard. Question number 7. A technique used to deliver high dose of anti-cancer drugs directly to a limb is known as red, HILEC, blue, isolated limb perfusion, yellow, in situ preparation, or is it green, Ferguson's technique? One of these is a technique to deliver high dose of anti-cancer drugs directly to a limb. Is it HILEC? Is it isolated limb perfusion? Is it in situ preparation, or is it green, Ferguson's technique? The correct answer is isolated limb perfusion.
Yeah, so isolated limb perfusion is a technique where we use for certain locally advanced limb cancers like clear cell sarcomas or epithelioid sarcomas, where we use a high dose chemotherapy in the limb, isolating it from the rest of the body by using some tourniquets. So this is a technique which is found to be effective in this kind of tumor.
Yes, so the correct answer is blue. Let's go on to the next question. And there is again some changes in the leaderboard happening. Very good. Let's see the next question. The 8th question. In situ prep is a technique used in sarcoma surgeries for protecting the growth plate, protecting the joint involved, protecting the neurovascular bundle, or is it protecting the tendons? In situ preparation is a technique used in sarcoma surgeries for red, protecting the growth plate, blue, protecting the joint involved, yellow, protecting the neurovascular bundle, or is it green, protecting the tendons? One of these is known as in situ prep. And the correct answer is yellow, protecting the neurovascular bundle. So, sir, if you can just shed some light on that.
So basically, in situ preparation, when like I think Dr. Jagandeep has shown some examples, when the nerve is going through the tumor, if we are not able to do an epidural dissection, we can isolate the tumor, open the tumor along the major nerve. When the vessel is involved, we can reconstruct by putting a vessel graft. When the major motor nerve is involved, we can isolate the tumor by putting plastic sheets, incise the tumor there, take out the nerve and treat it with alcohol to kill the tumor cells, and that is called as an in situ preparation. And we can keep the nerve.
A way to protect the neurovascular bundle. We'll go to the next. So at the end of this question, Saravana is still leading, followed by Lesencia and Adi. Now we have got last 2 questions, and we'll have a look at the leaderboard at the end of 10th question now. Moving on to the 9th question. People have to be correct and quick. The surgical procedure wherein the femur is resected and tibia rotated and articulated to a hip joint is rotationplasty type A1, rotationplasty type A2, rotationplasty type B1, or rotationplasty type B2. One of these types is a surgical procedure wherein the femur is resected and the tibia is rotated and articulated to the hip joint. Is it A1, A2, B1, or B2? The correct answer, oh, there is a spread of the answers, but the correct answer is green, rotation plasty type B2.
So basically, I think all of us have need to read the types of rotation plasty here. Because type A are the knee rotation plasties and type B are the hip rotation plasties.
Yes.
So basically what we are doing is we are forming a hip joint. So basically it becomes a type B. Got it?
Yeah.
And B1, B2 and B3 are basically depends upon how much of the femur you are resecting. If there is only proximal femur which is being resected, distal femur articulating to the ilium is called as B1. Okay. So, but when the total femur is resected and tibia is articulated to the hip joint, it's called as B2, or I think it's B3.
The answer here is, I think, is B3, sir.
B3 is not
yeah.
B2.
Yeah, B3A.
B3A.
There is
Yeah,
a
which is
typo
B3A.
there. Yeah.
So it is called as type B. The answer will be B, not B1, because B1 is for the proximal femur, not for the total femur.
Yes. Yes.
So,
Yes.
so I don't know, like when how you are going to mark this, because the answer is not also B.
So answer is not B1. So
it is not. It is definitely not B1,
not B1.
because B1
Yes,
is
yes.
for proximal femur. Yeah.
Yes. So we'll give it for the people who have answered green.
Yeah.
Okay. So that was a controversial one. But moving on to the last question of this quiz, we'll skip the leaderboard if possible, so that there's a suspense on who's leading the leaderboard. So Somnath ji, let's have the last question. In relation to limb salvage surgeries, what does CATS stand for? Is it curettage and allograft in tumor surgery? Is it cryotherapy assisted tumor surgery? Is it computer assisted tumor surgery? Is it cortical aperture for tumor surgery? CATS stands for curettage and allograft in tumor surgery, cryotherapy assisted tumor surgery, computer assisted tumor surgery, or is it green, cortical aperture for tumor surgery? And there's a difference of opinion here, but the correct answer is yellow, computer assisted tumor surgery.
So nothing in that, it's just the full form of CATS. Okay.
Yes. It's the latest advancement where we use navigation and maybe use jigs and all. So that concludes the 10 questions. Now let us see who is on the top of the leaderboard. So at number 3, we have Barry. Very good.
Barry is back again.
Yes, and number 2 is Adi, and number 1 is Saravana Varana. Congratulations, Saravana Varana. We have Lesencia at number 4 as well. So Saravana, if you're around, can you just switch on your video and maybe speak a few words on how did you find today's session and the quiz, and are there any feedback for us? Saravana, are you there? I can see you, Saravana Kumar. You can unmute yourself. Yes, hi. You'll have to unmute yourself.
Yes, sir.
Yes. So Saravana, congratulations on winning the quiz.
Thank you, sir.
Yeah. So how was your experience of the whole session and the quiz?
Very useful, sir. Very useful. I have understand a lot of principles and basics.
That's good. So any feedback other than that? Do you any areas you want us to cover?
Actually, surgical procedures, if we can see, it will be much useful, sir.
Okay.
So we can learn many techniques, intra techniques we cannot be explained in.
Okay. Yeah, maybe that is something to think about and consider. But very thank you for participating and winning. And thank you to all. Thank you, Manish sir. Thank you to the panelists for taking time out on a Saturday evening and contributing to this.
Thank you. Thank you.
I think we've come to end of today's session.
Yeah. Thank you very much. Thanks a lot, everyone.
Thank you, everyone.
And congratulations to the winners. Yeah.
Yes.
Thank you.
Thank you, Somnath ji and Hemant ji.
Thank you, sir.
We couldn't flash that flyer for next session.
Yes, sir. थोड़ा
ठीक है,
बात करने में मिस हो गया.
हाँ,
Yeah.
चलेगा.
You can calculate for at least in your groups for the program.
Yes. Anyways, I think the final list is ready. तो है ना कि आपको मिला है वो final with the panelists and all.
आपने जो मेल किया था वो है, वो फाइनल है या कुछ चेंजेस है?
अच्छा, उसमें थोड़े और पैनलिस्ट ऐड करेंगे हम. तो
3-4 दिन में आप बता दीजिए.
हाँ जी, ठीक है, चलेगा. Thank you, thanks a lot.
Yeah. Thank you, sir. Thank you, Somnath. You can end the meeting.
सोमनाथ जी, I think आपके ऑडियो का कुछ इशू है.
हाँ सर, थोड़ा लैपटॉप का उनका इशू है.
हाँ, क्योंकि काहूट ऐप का जो साउंड है वो नहीं प्ले हो रहा था.
ओके, चलेगा. हम लोग नेक्स्ट
डेमो एक्चुअली सेम इशू मेरे लैपटॉप पे भी है, इसलिए आई आस्क्ड हिम टू प्ले इट.
ओके,
ठीक है, कोई बात नहीं. विल सी इन द नेक्स्ट सेशन. नेक्स्ट सेशन में क्विज नहीं है, इट इज अ केस प्रेजेंटेशन सेशन.
ओके सर.
क्विज नहीं रहेगा सर उसमें?
नहीं, उसमें नहीं हो रहा है, वो सिर्फ केस डिस्कशन है उसमें.
ओके सर, ठीक है सर. थैंक यू सर. मैंने आपको डिटेल भेज दिया फेब का वाला.
चलेगा. आज का भी आई थिंक स्क्रीनशॉट भेज दो मेरे को, तो दोनों को साथ में ईमेल कर
भेज देता हूँ मैं सर.
ओके.